Sure that this is a big opportunity to avoid monotony of a single specialty of yours respectively and to learn from stalwarts of other fields to keep us updated in other fields of medicine too. नहीं तो बहुत जल्दी काला अक्षर भैंस बराबर हो जाता है. So, we will all be benefited from this conference and I look forward to see you all in the next coming interesting session. As per our culture and not just mere attention, we begin with IMA prayer and flag salutation. I request everyone to please stand up for IMA prayer. May everyone be happy. May every one of us see to it that nobody suffers from any pain or sorrow. I do not ask for crown, nor I wish to be in heaven or reborn. I only want to alleviate the suffering of those people who are burning in fire of sorrow. I am a flag salutation. We, the members of Indian Medical Association, stand here to salute our national flag. Its honor and glory shall be our light and strength, and its course shall be our course. We pledge our allegiance to it and realizing our responsibilities as the accredited members of this national organization. We swear we will dedicate everything in our power to see it fly high in the Committee of Nations. Jai Hind. Jai Hind. Please be seated.
So let's begin our day with a beautiful sessions in row. To chair the sessions, I invite Dr. Ravindra Pasle sir, Dr. Kailas Ben Parikh madam, and Dr. Vipul Gandharva sir on the stage. Dr. Pasle sir is a very senior pathologist. Dr. Kailas Ben is a past president of IMA, and Dr. Vipul Gandharva is an anesthesiologist. Now, I welcome Dr. Dhaval Bamania sir on the stage for his talk on an important topic for every specialty of medicine named interpretation of CBC and its new parameters. And I request the chairpersons to introduce Dr. Dhaval Bamania sir.
Hello.
Everybody, it's my great pleasure to introduce Dr. Dhaval Bamania, who is a hematopathologist from Surat. He has many special achievements to his credit. His special interests are flow cytometry and coagulation. And though these, he's going to talk on automation and new parameters in automation, besides the traditional parameters of hematology analyzers. I request Bamania to begin his talk.
Thank you, sir. First of all, good morning, and thank you, Gimacon, for inviting me. Let's begin the session. Interpretation of CBC and its new parameter. These are the CBC parameters, some of which are common, some of which are uncommon, some of are absolute parameter. Let's see. So the first question is why it is important to know histogram or scattergram, because for the consultant, being a consultant, we should know all the parameters and all the meaning of all the tests that are being done and all the tests that are being advanced. So these are the histogram. This is basically, this is mainly based on the three-part parameter and impedance method. And these are the scattergrams. Scattergrams are mainly used in the 5-part, and it is it's basically flow cytometry method. So let's talk about the case number 1. The 25-year male presented with the complaint of the weakness and the having low hemoglobin. While looking at the CBC, WBC and platelets are normal and HB is low and MCV is low. So mostly it would be microcytic hypochromic anemia. So the most common DD would be the iron deficiency versus thalassemia minor. So let's see how to differentiate without being see the slide. On the basis of this CBC parameter, how will you differentiate between the iron deficiency as well as thalassemia minor? So this is the case of microcytic hypochromic anemia. MCV is 58. So if it is iron deficiency anemia, it has to have elliptocytes, because the iron deficiency of iron causes the reduced elasticity of the RBC membranes that causes the elliptocytes. Okay, so this is the reason why the why RDW is raised 20. While looking at the smear, these are the elliptocytes which is characteristic of iron deficiency anemia. When doing iron studies, it's suggestive of iron deficiency anemia. Now the similar case comes. 25-year male presented with the complaint of the weakness and found to have low hemoglobin. Similar type of MCV. MCV is 60, 9.9, and RDW is normal. Normal shows homogeneity of the RBCs, and there is no or mild variation in the RBCs. But the hint here is RBC count is raised 5.1. It suggests a hemolytic anemia that is suggestive of responsive marrow. So while seeing the smear, these are the target cells that is characteristic of hemoglobinopathies. And on HB electrophoresis, HbA2 is elevated. So it is suggestive of beta thalassemia minor. Case number 3. A pregnant woman expecting twins presented to her physician, scheduled for ANC evaluation. CBC showed hemoglobin, MCV, MCH values are almost normal. Hemoglobin is 11, 9000 WBC, and platelets are 250. And while looking at the smear was also normal and normal looking cells, but few were showing some microcytic hypochromic cells. So the physician ordered the reticulocyte panel. Then the RAT HB was extremely low, that was 20 picogram, and normal value was 29 to 35, and further ferritin was done. Ferritin was extremely low. Subsequently confirmed that patient has absolute iron deficiency, and this was the classical case of latent iron deficiency. The patient was going to have iron deficiency stage, but thank God it was detected so early. Now the question is, what is RAT HE? RAT HE is the parameter hemoglobin content of the reticulocyte, that is reticulocyte hemoglobin equivalent. And it is mainly seen in immature cells. It is early and direct assessment of the available iron to the reticulocyte, that is a precursor form of RBCs. It is highly accurate and routine laboratory analysis. And the benefit of RAT HB that not only in the diagnosis, it can also be used in the therapeutic. It detects the direct bioavailability of iron. And the one more parameter is delta HE. Now the RAT HE is the earliest parameter, and it shows the if RBC is being made today, then it shows the bioavailability of iron in the new RBC. After 2 to 3 days, this reticulocyte count gets mature into the RBC. So once again we will measure the RBC HE, that is the hemoglobin iron measurement in the RBC, and the difference between the RBC and RAT HE would be called delta HE. If it is low, then it would be suggested patient is not having proper response to the therapy, and if RBC HE is higher than the RAT HB, then the patient is classically responding to iron deficiency anemia. So these are the some profits and benefits of RAT HE. Qualitative information as well as the prognostic information. Now have a look at reticulocyte count. That is automated. Automated reticulocytes are of three types: lower, moderate, and high fluorescent reticulocyte count. High means that is the early reticulocyte count. Medium means intermediate, and lower means late reticulocyte count. When the when the reticulocyte count is showing high fluorescence rate, means it is having more number of RNA, and more number of RNA means more high fluorescence. So the one term is there, immature reticulocyte fraction. It is the sum of high reticulocyte count and intermediate reticulocyte count. So these are we can see these are the high reticulocyte count, intermediate and late reticulocyte count. And the benefits are it not only useful in the diagnosis of the anemia, but it also causes the prognosis of the anemia as well as the therapeutic response to the anemia. Like if we see, these are the aplastic anemia. This circle shows lower number of early reticulocyte count as well as lower number of total reticulocyte count. In contrast to that, in hemolytic anemia, we can have the high number of reticulocyte count as well as high number of early reticulocyte count. And in the dyserythroid MDS or megaloblastic, we are having high number of early reticulocyte, but overall reticulocyte count is low because it is the nutritional anemia. And the case number 4, 19-year male presented with the low platelet count. While looking at the CBC, everything was normal except this platelet count. Platelet count was only 27,000 and it was showing thrombocytopenia. But while looking at the scattergram, these are the some abnormal population on the microscope. It was showing some reactive cells that was suggestive of viral infection. Further, PCR dengue was done and it was positive. So patient was diagnosed as dengue positive cells. But the question is, patient was going to the Goa for the Diwali trip. Patient said, sir, मैं क्या जा सकता हूँ अगर मुझे कुछ lower platelet तो नहीं हुआ ना? So get done. Immature platelet fraction. What is IPF? In this patient, the IPF was 10, and so patient was discharged. So what is the IPF? IPF is the immature platelet fraction, and that is the immature form of platelets. Need not to be necessary every time that is large in number, but it is the immature platelet, early precursor form of platelet. And early precursor forms are having more number of RNA that shows the more number of fluorescence, and that are being shown here in this area. And these are the mature RBC, and these are the immature RBCs that are reticulocytes count. So if the patient is having more than 10 IPF, then you can also discharge the patient, and it is suggestive of not only the diagnostic but suggestive of patient is going to have increased platelet count in 24 to 48 hours, as well as it can also guide us in the whether the patient would be having the any prophylactic platelet therapy or not. And increased IPF generally shows bone marrow is responding, bone marrow is basically generating. In the bone marrow failure syndrome or aplastic anemia or after transplantation, the bone marrow is not responding so much. So IPF value in that case is almost nil. In the normal patient, there is moderate number of IPF, and in the highest number of IPF is seen in the patient with ITP or peripheral destruction. So it was observed that 93% patients respond in 24 to 48 hours if IPF is more than 10%. So it is mainly useful in the if the patient is having transfusion, if patient is requiring transfusion of platelet or not. So the question is, अब तक ये कहाँ पे था, अब तक ये क्यों नहीं है? Because we were using 3-part old method. So in the 3-part, in the one graph, all the platelets as well as the RBC are measured, and these are the gray zone, whether it would be either the large platelet or the microcytic RBC. So it was some mismatch between the RBC and large platelet. So here comes the role of the scattergram, and here comes the role of the flow cytometry method, 5-part cell counter. So case number 4. Now this is the somewhat interesting case. 42-year male presented with the decreased appetite, abdominal mass, weakness. So while looking at the CBC, WC count is massively raised, 98,000, 11 hemoglobin and 91,000 platelet. So the important was that instrument is showing immature granulocyte flag, and if we look at this scattergram, these are the mature lymphocyte, mature monocytes, and these are the mature neutrophil. neutrophil, but these are some abnormal cells. It is suggestive of some cells are greater than the neutrophils as well as in granularity, mostly suggestive of blast, myelo, metamyelo, and promyelocytes. So it was the classical case of CML. Patient was having splenomegaly and blood pictures show all the cell series. The BCR-ABL major was positive, Philadelphia positive, MPN, and that was the MPN. But the role of instrument in this case is it was showing immature granulocyte flag, and these are the some immature granulocytes that are blast, myelo, promyelo. So the IG flag is very much important in the diagnosis of early, it is the early marker of the infection before the CRP and procalcitonin gets raised. So in the clinical practice, we can judge whether the patient is going to have the hospitalization or not. If the IG is positive or IG is high, you can always admit the patient and always start the antibiotic. And this was the another case, classic case of infection. IG flag was 5.2, 5,200 absolute count. This was the case 6, 60-year male patient, diagnosed case of CLL, presented for the routine CBC evaluation. While looking at the smear, WBC was obviously 20,000. Hemoglobin was 6, but the interesting thing was MCV was 533, which is never possible. Generally, rule of 3 follows. RBC into 3 is equal to hemoglobin. Hemoglobin into 3 is equal to HCT. But here, the RBC is 0.1 and rule of 3 is not followed. Okay, so instrument is clearly suggesting that I am having some abnormality in counting RBC count. While looking at the RBC flag, RBC graph, it was not regular graph. So further we looked at the marrow because it was the CLL. While looking at the smear, these were the RBC aggregates. This was the RBC aggregates, and in the CLL is the B cell clonality disorder, and that shows patient might be having autoantibodies. So this was the case of cold AIHA when we put the sample in the incubation at 37 degree for 30 minutes, and after that we repeated the sample and we run the sample again. The hemoglobin was 6, it was unchanged, but RBC was normal, and so the HCT was also normal because HCT gets calculated from the RBC count. But the interesting thing was WBC was increased from 20,000 to 24,000, and platelet was from 60,000 to 1,02,000. These happened because some RBC and WBC gets entrapped into the RBC aggregate, into the RBC big clumps and big aggregates. So they got released. So this is the reason why WBC and platelets are increased in the further after incubation of 37 for further 30 minutes. And if we look at the RBC graph, it is near normal, and flag of the RBC abnormal distribution was gone. These are the 4 cases of pancytopenia. On the basis of, I will not look at the smear, on the basis of these parameters, we have to diagnose whether it is 4 DDs of aplastic anemia. And these all are having pancytopenia, but all 4 cases are having different diagnosis. Now look at the first case. The patient is having WBC 1500 only, 6 hemoglobin and 1000 only platelet. So it is in the category of severe pancytopenia. When looking at the smear, when looking at the DC, the lymphocyte was predominant because the lymphocyte neutrophil has the shorter half-life than the lymphocytes. This is the reason why lymphocyte is predominant. And severe pancytopenia, lymphocyte predominant, no giant platelets and no NRBC. That is suggestive of marrow is not responding and there is no generation of platelet as well as NRBC. No abnormal cells, leukemia is ruled out, and normocytic or mildly macrocytic RBC. While looking at this biopsy, it was the empty marrow that was suggestive of aplastic marrow. So mind well, in aplastic anemia, you will have the severe pancytopenia as well as lymphocytic predominant. And please rule out the history of drug. The second case shows hemoglobin 4, only 3,000 WBC count and 63,000 platelet. It was somewhat moderate, mild to moderate pancytopenia. While looking at the DC was almost normal, but when looking at the smear, giant platelets were present, NRBCs were present, and hypersegmented polymorph. And MC here in this case, MCV is near to the normal 98. But when looking at the this RBC graph, there are two type of population, normocytic as well as macrocytic population. So this is the reason why RDW is raised. Okay, so this was proved to be a megaloblastic anemia because of the macrocytes. These are the macrocytes and hypersegmented polymorph, and also the marrow is responding. But because of the nutrition, because of the B12, it was suppressed. Now the third case. The third case is 20-year female having mild to moderate pancytopenia, 8 gram hemoglobin, 2,800 WBC and 181 almost normal platelet count. While looking at the DC was absolutely normal, and these are the smears. Smear was also showing absolutely normal, normocytic, normochromic. Some giant platelets are there and neutrophils are normal. So marrow is responding. That means the patient is having either peripheral destruction. So when doing the general examination, spleen was moderately enlarged. So these would be the case. This would be the case of the hypersplenism, and when we look at the RBC graph, these are some microcytic and these are normocytic. Patient was having blood transfusion history, and this is the last case. The patient is having mild to moderate type of pancytopenia, WBC 3,000, 8 gram hemoglobin and 22,000 only platelet. DC was normal, and while looking at the smear, these were the some abnormal polymorph that was called as pseudo-Pelger-Hewitt anomaly. And in the scattergram, generally polymorph lies in this place, but these are abnormal polymorphs, so they lies on this place. And some hypogranular platelets were seen. You can see in this platelet some degree of hypogranulations, if, especially some few pathologists can appreciate it very well. And abnormal cells were there, old age, and further the cytogenetic was done, and it was showing trisomy 8, further confirms the diagnosis of MDS. So this was my take-home message. Each and every person who is practicing medicine, be techno-savvy, take as much as possible advantage of technology, and also always communicate and discuss with the pathologist to unmask the hidden pathology. Always prefer the technology-dependent parameters. This is my team of doctor here at Vadodara. Thank you.
Thank you. Any questions?
Hello. Thank you, Dhaval, for nicely explaining both the traditional parameters and the novel parameters.
Thank you, sir.
Yes, you can ask questions.
Being a pediatrician, it's always, this jargon is slightly difficult for us. So much new parameters what you explained. So is there the same parameters are followed for the children's also, or it's age specific markers are also decided now?
No, sir. I think IG parameter is very much useful for the pediatricians because it is elevated just 2 to 3 days before the CRP. Because I observe that most of the pediatrician gets done CBC and CRP. So IG parameter gives the flag 2 days prior to the CRP gets raised and procalcitonin gets raised. So these would be the very much informative parameter for the pediatrician, as well as pediatrician like 5 to 7 years or 5 to 10 years of age are having more number of dengue infection than the infant age. So in that case, you can always do the IPF parameter to avoid the further platelet transfusion.
And please give some light on the reticulocyte count variations.
Sir, like if we discuss in the deep, each and every nutritional parameter has the low reticulocyte count, because the hematopoiesis is being suppressed only because of the malnourishment. Now, if we talk about the megaloblastic anemia, there is more number of early and intermediate reticulocyte count than the late reticulocyte count. Means production is there, but it won't get mature, so they get lies in the bone marrow. So this is the reason why LDH is raised. So overall reticulocyte count is lower. Now, I will give the B12 therapy and folic acid to the pediatric patient. So, the pathology is such, early and intermediate reticulocyte count was there. वो तो होता ही है, लेकिन they get mature into the late reticulocyte count. Okay, so further reticulocyte count is also increased, as well as early, intermediate and late reticulocyte count is increased, and they get mature into the RBC count. So this is the mechanism why HB is raised. So we can diagnose and get having prognosis of this course of the treatment. Like hemolysis, in hemolysis we can also measure the early, intermediate and late reticulocyte, and all are high, and this is the reason why reticulocyte overall count is high. Where in contrast to that, in nutrition and anemia, reticulocyte count is low, but if we look at the early and intermediate reticulocyte count, it is high. So this was the mainly importance of reticulocyte count.
Thank you.
Thank you. Friends, like
Thank you,
we
Dr.
did yesterday,
for excellent presentation.
let's do our, yes sir, go ahead.
Pati?
So friends, like we did yesterday, let's do our new normal. Let's stand up and applaud our very first batsman of today. Thank you, Dhaval sir, for your excellent talk, which is fulfilling our theme, that is science beyond the boundaries of speciality, knowledge for all. Now I welcome you down the stage for the felicitation, for which I request Dr. Ravindra Pasle sir to come down the stage to present memento to Dr. Dhaval. Now I welcome our very young and energetic, very meticulous speaker, my friend Dr. Shreyas Patel, on the stage for his talk on approach to an unconscious patient, and I request the chairperson to introduce Dr. Shreyas.
Good morning. Dr. Shreyas Patel, he is in emergency medicine, disaster medicine and simulation-based learning. His interests are like this. He achieved American Heart Association Instructor, Fellowship of Academic College of Emergency Expert. He has Jan Suraksha Paritoshik Inducem Award in 2022, and as he is very young and dynamic for other career, he is former Senate member, MSU, Baroda.
Thank you, ma'am. Thank you for the introduction. So let's now move to our topic. So suppose you are there in your private setup or in the emergency department, and it's early morning, 11 a.m., your hospital is full of OPD, and suddenly you get a call, and suddenly you get a call from the nurse that you are having a adult person, 54-year-old male, which is unconscious in your setup. So what will you do? So here we are to learn how to approach a patient who is unconscious in your setup. So let me introduce myself once again. Myself, Dr. Shreyas Patel. I am working as an associate professor in Parul Institute of Medical Science and Research. And today's our objective of this talk is, we'll identify that what is unconscious patient, understand the approach to an unconscious patient, will understand how to perform a focal neurological examination, how to take a focused history, and understand the structural and the non-structural causes of unconsciousness. So first of all, let's begin with the approach. So first thing is confirm whether patient is really unconscious or not. So how can we confirm? We have to determine the unresponsiveness. First, directly by visualizing. By visualizing, if patient's eyes are closed, patient is immobile, there is a lack of facial expression, there is a no response to external stimuli, then we can label that yes, patient is unconscious. For further confirmation, we have three things. We can do a verbal stimulus, we can do a tactile stimulus, and we can do a noxious stimulus. Means we can simply ask, hey, how are you? What happens to you? Or else we can clap loudly to confirm that patient is really unconscious. We can use the tactile stimulus on any of the body part, like predominantly we'll use the face and the hand, and at the end we can also use the noxious stimulus. That should be intense but not that much to cause the tissue injury. The recommended manners are, we can just sternal rub, we can do a nail bed pressure, we can pressure on the supraorbital reach and posterior aspect of the mandibular ramus. After confirming that patient is not showing any kind of response, means patient is really unconscious, the next step is to do its basic management, that is ABC and C spine stabilization. So ABC, it means the airway breathing and the circulation. We have to quickly check whether airway breathing circulation is fine or not, and we can concurrently treat it. If patient is of a trauma, you feel that patient is having trauma over there, then it's necessary to stabilize the cervical spine too. You can rapidly check head to neck, head to toe, head, neck, chest, abdomen, and the extremity. Apart from that, the most important or the most necessary thing that you have to do is you have to check the blood sugar, because it's the rapidly corrected thing. So if your blood sugar is less than 70, you should immediately give the dextrose 50 ml of 50%. If you feel that patient is alcoholic or a bariatric surgery patient or patient with a malabsorptive stage, so in that case it's necessary to give thiamine 100 milligram along with the dextrose. So after checking this ABC and the C spine, our next step is to do neurological assessment. So what will you do in the neurologic assessment? In the emergency department, or if you have a busy OPD, it's not possible to do a detailed examination. So we'll do it a focus neuro examination. So focus neuro examination has mainly 4 parts. We'll see one by one. The first part is the level of consciousness. How can we check? We can check by the Glasgow Coma Scale or the 4 scale. There is a limitation of the Glasgow Coma Scale that it doesn't include the brainstem examination. So we have the another 4 scale. We just quickly look what is GC scale and what is 4 scale. So GC scale we have 3 components. One is eye, one is verbal, and the one is motor. We all know 4, 5, and the 6. That is the maximum that we can give. And what is 4? 4 is having the eye response, motor response, brainstem reflex, and the respiration. So that it will also emphasize on the brainstem. That is very much important. Apart from this Glasgow and the 4 scale, we can also check about the whether patient is able to fix his visual acuity, whether patient is able to track your finger or the movement, and how patient is responding to your forced eye closure, whether he is resisting the examiner or not. So after that, the second step that we can do, that is brainstem examination. In the brainstem examination, we'll mainly focus on the pupils, pupil size, reactivity, and the symmetry. We'll can check the corneal reflex, threat response, oculocephalic reflex, vestibulo-oculocephalic reflex, and gag reflex, along with the cuff reflex. Next thing is the check the motor function, whether patient is able to move spontaneously or not, whether patient is responding to verbal command or not, and whether patient is responding to noxious stimuli or not. After that, the last part, that is breathing pattern. We can get the lot more information by the breathing pattern. If breathing pattern is abnormal, then you can also diagnose that which kind of issues patient may have. So in case of the neurogenic hyperventilation, it could be pons or the midbrain which are damaged, or they have some issues. In case of the cluster breathing, pons may be responsible, and absence of the spontaneous breathing, ataxic breathing, and the cluster breathing lesion may involve the medulla. So this 4 thing is the important part that we can quickly check and quickly assess about neurology. After that, assess for the readily reversible causes. The one cause we already discussed, that is hypoglycemia. Majority of the time, hypoglycemia can cause the altered mental status or the coma. So if there is hypoglycemia, we can immediately give the dextrose and patient immediately respond to that. After reversible causes, we have to do a focused history. Focus history, our main target is to identify the quick medical and the surgical history, whether a patient is on any medications or not, whether he is taking alcohol or not, whether a patient is having any illicit drug use, environmental exposure, or evidence of any trauma. That's it. No detailed history. So after this, we have to find for the causes. For that, we can take a help of laboratory study. Laboratory study, we can advise for the hematology panel, we can advise for the serum chemistry, we can do the ABG, we can do the microbiology, and if your setup is for that, it allows, you can also go with the toxicology. After laboratory, most of the time, we will find the cause of unconsciousness. So the main part is the neurological examination, that is pupil, brainstem, and the motor response, that will focus on. In the focused history, we'll focus on the medication and the exposure, and in the laboratory, we'll do this. So what could be the causes? Causes could be either it is structural, either it is non-structural, or it may unclear. So in the unclear cases, the main role is the brain imaging. Even in the structural causes too, the brain imaging is the main part. So what do you mean by structural? So if you find any kind of abnormality during your examination, then there is a chances of you may get a localized brain lesion that you should find for. The structural etiology is mainly suggestive by history, physical examination, absence of any other etiology, or a new onset of seizure, or change in seizure pattern. So the most important part that you should do in this case is to do the CD. CT will mainly give you the idea. Structural causes are like traumatic brain injury, ischemic stroke, cerebral hemorrhage, meningitis, encephalitis, and brain tumor or the other mass. And management will require the involvement from the neurology and the neurosurgery. So the brain imaging, that is most important part in this. So we can offer the head CT to identify the ischemic stroke. In many cases, you may find the basilar artery thrombosis as an initial part, acute ischemic stroke. For the MRI, to identify hyperacute ischemic stroke or the other findings. And if you think that there is a possibility of the infection, then you should go for the cranial CT with or without contrast. So there are list of other causes too, like the metabolic coma in the non-structural causes. So in the metabolic causes, it might be encephalopathy, seizure, endocrinopathies, systemic infection, CNS examination. So if you want to look in a brief, it is divided into metabolic encephalopathies, drug overdose, or environmental causes. So after brain imaging, majority of the time we'll find a cause, that is trauma, stroke, SH, or the tumor. And in the non-structural or the non-focal examination, for the metabolic cause, we'll get majority of the time amongst this hypoglycemia, hyperglycemia, electrolyte disturbance, drug overdose, seizure encephalopathy, sepsis, or the CNS infection. But what if there is a uncertainty that you are not able to find any cause, right? Then what you must do, you have only few options, like you can do the CT to find the consider basilar artery thrombosis that many times missed, EEG to identify the other causes like seizure, burst suppression, or the metabolic encephalopathy, lumbar puncture, and MRI. So these are the only things that you can do to identify cause, and it will majority of the time it will give you the clue what you are dealing with. So at the end, how to approach a patient with a stroke. So the first step is to do ABC and the C-spine. After that, neurologic assessment. If you have any reversible condition like the hypoglycemia, you should immediately address. Focus history, mainly medications at the exposure. We have to give the laboratory study examinations, and it will, majority of the time, will give us the clue of the unconsciousness. Unconsciousness or the coma will follow in a 3 different pattern. Either it will be the structural or non-structural or the unclear. The only thing that we have is the brain imaging. Majority of the time we'll get a cause identified, and apart from that we have the metabolic cause that will get the idea with the help of blood reports or the other chemistries. So I think at the end we have identified the unconscious patient. We understand how to approach an unconscious patient, how to do a focal neurological examination, how to take a focus medical history, understand the structural and the non-structural causes of unconsciousness. So I am here for the questions. Thank you. Yes. So I think just before this question, I would like to highlight that I would also like to hear from you. You can just scan it and you can give me feedback. Yes, sir, please. Hypoglycemia, the other thing is hypoxia many times, and the hypoglycemia. Hypoxia is mainly common in the pediatric cases, but in the adult cases it is hypoglycemia majority of the time. Thank you. So please don't forget to scan it and give me a feedback. Yeah, I think that's it. Thank you. That's it from my side. Thank you so much.
So friends, let's be conscious about what is going on. Let's re-stabilize your spine and posture. Let's stand up and give him a big round of applause.
Thank you.
Thank you, Dr. Shreyas, for an enlightening talk. Now I welcome you down the stage for the felicitation, for which I request Dr. Kailas Ben Parikh to present the memento to Dr. Shreyas Patel. Now I welcome Dr. Vibha Nayak Madam on the stage for her talk on approach to resistant anemia, and I request the chairperson to introduce Madam.
Good morning. Welcome, madam. Dr. Vibha Nayak, madam. She is DM Oncology, hemato-oncologist. She has done in 1991 MD General Medicine. She is gold medalist in Oncomedicine in 1994. She is director of 50-bedded Nayak Super Speciality Hospital since 1996. She is honorary consultant, oncologist and hematologist at SSGH, and she is founder of NGO We Can for needy cancer patient. Thank you, madam, and I welcome you to present your lecture, ma'am. Thank you, ma'am.
So, good morning, everybody. It's a great pleasure. I am thankful to the organizers of Gimacon to have invited me, and respected chairpersons, with your kind permission, I can begin my talk on resistant anemia, refractory anemia, or unexplained anemia. They are all the same. So as the theme of Gimacon goes, that it is knowledge for all. So anemia is one subject. Through all specialities you will be seeing anemia. And many a times we are stuck. What is the cause of anemia in our patient? So very quickly I'll just go through the basic highlights of my talks. So what is unexplained anemia? Anemia of more than 1 month duration, non-nutritional, which is affecting quality of life. So we divided into anemia of chronic disease, anemia of hematological disease, bone marrow failure syndrome, drug-induced and chronic deficiencies. What is anemia of chronic disease? So any disease or any illness which is of more than 2 months duration, and the degree of anemia is related to the degree of an illness. So if more the fever, more the patient bedridden, more the anemia. Usually the anemia is normochromic normocytic. The serum iron is low. Remember, serum iron is low transferrin saturation is low and ferritin is high. So this is very important in anemia of chronic disease. High fibrinogen, ESR, CRP, and it is also known as cytokine-mediated anemia. We all have heard a lot about cytokines during COVID. So cytokines are inflammatory hormones and they are secreted by the B cells, and this causes anemia. So the cytokines like TNF, interleukins, interferons. Now what do the cytokines do? They increase the level of hepcidin and decrease the level of erythropoietin. So anemia of chronic disease is because of chronic infections, connective tissue disorder, and malignancy. So mainly you will have the chronic infections are the pulmonary infections, especially tuberculosis, pelvic inflammatory diseases, subacute endocarditis, osteomyelitis, chronic urinary infections, chronic non-infectious inflammations, that is the connective tissue disorders, malignant diseases, ischemic heart disease also long-standing causes anemia of chronic disease. So if you look at the iron cycle in humans, which is very important to understand, that iron is absorbed from the intestine, and in the plasma it is bound to transferrin. From there it is taken up by the bone marrow and incorporated in the erythrocytes in the form of hemoglobin, which are then circulated in the blood. These erythrocytes after 120 days are taken up by the macrophages in the reticuloendothelial cells. The iron is again released into the plasma and the excess iron is stored in the liver. So any disorder in this cycle will cause anemia. So what is hepcidin? It is very important to understand that hepcidin is a hormone secreted by the liver, and increased level of hepcidin causes low absorption of iron, and decreased level of hepcidin causes increased absorption of iron from the intestine. So when there is iron loading or chronic inflammation, if you can see at the left side on the top, there will be increase in level of hepcidin. So this hepcidin will cause decreased absorption of iron from the intestine. While if there is an erythropoietic signal, like if there is hemolysis or if there is blood loss, there will be low level of hepcidin and more iron will be absorbed from the small intestine and taken up and it's bound to transferrin. So anemia of chronic disease is because you will understand one thing, that any chronic disease is an inflammation and there is oxidative stress, and iron increases the oxidative stress. So it is like adding fuel to the fire. So what does the body do? It conserves iron. So what it does is increases the level of hepcidin and decreases the level of erythropoietin by cytokines. So anemia of chronic disease is also known as cytokine-mediated anemia. So this is the basic way how it happens. Anemia of chronic disease, hepcidin increases, low erythropoietin, and decrease in iron, also decreased RBC survival because of hemolysis. So basically the iron deficiency states are the absolute iron deficiency which is caused by blood loss, the inflammation, any chronic inflammation will cause iron sequestration, and functional iron deficiency because of erythropoietin stimulated erythropoiesis which is impaired. So anemia in chronic kidney disease. 50% of the patients are affected. It is more common in serum create more than 2.5. It is also normocytic, normochromic. The pathogenesis is that because kidney is the source of erythropoietin and there is an erythropoietin deficiency in CKD, this is the main cause of anemia. There is suppression of marrow erythropoiesis, shortened RBC survival. Again, in certain lupus patients which have CKD, there is cytokine mediated anemia. There is hemolysis when there is microangiopathic hemolytic anemia. Also CKD is associated with hyperparathyroidism which causes marrow fibrosis and loss of blood in the hemodialysis tubing. So this is the crenated cells in the renal disease, and this is the reason which they are the spiked cells which cause hemolysis and also one of the cause for anemia. Anemia in liver disease, 75% of patients with chronic liver disease or cirrhotic liver disease will develop anemia, again normocytic, normochromic, and the reason is that because of the cirrhosis, there is portal hypertension and there is congestive splenomegaly. So there is sequestration of RBCs in the spleen which causes hemolysis, and that causes shortened RBC survival. The membrane lipids are affected in chronic liver disease. Impaired erythropoiesis could be also because of alcohol, cytokines and bleeding from varices. So the macrocytes and target cells in the liver disease also are increased in size, which are also one cause of hemolysis and anemia. Anemia in endocrine disease, so when you have unexplained anemia, you should also look for hypothyroidism, diabetes, hypopituitarism, hypoadrenalism and hypogonadism. So most common is hypothyroid because in female it causes menorrhagia, low B12 because of intrinsic factor deficiency in autoimmune thyroid patients, and also for some unknown cause, hypothyroid patient absorb low iron, which causes anemia. The diabetic patients have renal involvement, which is one of the main cause of anemia, and long-term use of metformin also causes B12 deficiency and anemia. Anemia in hematological disorders, all the hemolytic anemia, sickle cell anemia, autoimmune hemolytic anemia, G6PD deficiency, and the microangiopathic hemolytic anemia, bone marrow disease, because of direct infiltration and cytokine mediated and coagulopathy, they cause anemia. So anemia in hemolysis, you have direct antigen test positive in autoimmune hemolytic anemia, sickling positive in sickle cell, thalassemia will have high HbF and A2, high indirect bilirubin because of hemolysis, serum LDH is high retic count because the marrow is going in an overdrive to produce more red blood cells, high D-dimer PT, APTT, INR in microangiopathic hemolytic anemia. This is one of my favorite slides which shows that what is the cause of anemia in sepsis, in cancer, and in connective tissue disorder. See, all these disorders will cause some level of microvascular stenosis, and because of the high stress, there will be breakage of erythrocytes, and that causes erythrocyte fragmentation and microangiopathic hemolytic anemia, and usually it is associated with thrombocytopenia. So reticulocyte count is a very important and sensitive indicator for any anemia. So if you have a high retic count, it is more suggestive of hemolysis or hemorrhage. So if you have a low retic count and if you have serum iron which is low, it is more suggestive of anemia of chronic disease. In that case, even the ferritin will be high. But if you have a low retic count with a normal serum iron, you should consider endocrine studies, renal studies, liver disease. You have to rule out these causes. So reticulocyte count is a very important and sensitive indicator of the cause of anemia. Chronic leukemias cause unexplained anemia because of direct marrow infiltration, and also it is cytokine mediated, but usually the patient is quite sick. Patient will present with fever, lymph node enlargement, splenomegaly, leukocytosis, and so you can come to a more importantly, you should know the symptoms of the patient when you are suspecting leukemia. So this is a patient of chronic lymphocytic leukemia where the peripheral smear is showing lymphocytes, the bone marrow is showing 30% lymphocytes, and lymphoma similarly, it is an anemia due to marrow infiltration. There is a history of fever, weight loss, lymphadenopathy. So symptoms are very important to understand when you are examining a patient of unexplained anemia. So anemia and myeloma. So you have to understand CRAB. C stands for calcium, so there will be hypercalcemia. R stands for renal involvement, there is renal involvement. A stands for anemia, and B stands for bone involvement, there are osteolytic lesion. But not all patients will present with these 4 symptoms. So usually the age is more than 50 years, there is fatigue, weight loss, backache, high serum create with normal sized kidneys, high ESR, high serum calcium, and you will have an M band on electrophoresis, and it is also because of the kidney involvement. The Bellstone's protein cause cast formation, and that decreases the erythropoietin level, which causes anemia. Anemia in cancer is because of bone marrow involvement, cytokine mediated in the later stages of cancer, and also cancer cachexia because patients are unable to take enough nutrition. Also, micronutrients also cause anemia in cancer patients. So anemia and bone marrow failure syndromes is MDS and aplastic anemia. So myelodysplastic syndrome is a patient which has not only anemia but also may or may not have neutropenia and thrombocytopenia. Isolated thrombocytopenia is rare, and patient may present with systemic symptoms in the advanced stages. So what is MDS? MDS is defective erythropoiesis. You have the marrow which is stimulated, which is producing cells. It is producing RBC, WBC, platelet, but they are defective in nature. So it is a defective erythropoiesis which occurs in MDS. And you will find that the patients will have megaloblastoid changes, multinuclearity, nuclear fragmentations, and unstained area in the cytoplasm. Also, they may have hypersegmented neutrophils, micromegakaryocytes. So these are the features of MDS. And they will be associated with lot of chromosomal abnormalities. Like in this patient, if you see, you will see that there is monosomy 7, and there is only one chromosome 7. You can see one chromosome 3, 4. So 3, 4, 7 are single. So there is monosomy, while there is trisomy 21. So these are complex karyotypes that you see in MDS patients. And the outcome in these patients is very poor. There is only one MDS which is associated with very good prognosis, and that is 5q minus. Where there is deletion of the 5th chromosome, you will have very good prognosis, and it is diagnosed either by karyotype or by FISH, and they are having a very good prognosis because you give an anti-angiogenic agent called lenalidomide, and most of these patients will enter into a complete remission. What is aplastic anemia? Unlike MDS, where the erythropoiesis is stimulated, in aplastic anemia, it is a dried well. There is no cellularity in the marrow. So what is the cause? It could be drug induced, like in our subcontinent, you know, we have a lot of patients taking NSAID for long period. So, or it could be viral. So we don't know, so cannot pinpoint the exact cause. So what is aplastic anemia? The absolute neutrophil count, the other series will also be affected. The absolute neutrophil count will be less than 500, platelet less than 20,000, retic is very low. And the immature platelet fraction is also very low. You have to also screen for PNH in these patients. So aplastic anemia, you will see in the bone marrow there is no cellularity. So not only one series but the other two series, the neutrophil series and the megakaryocyte series, so the platelets and the WBC count is also affected. So they are usually having a poor prognosis, they are transfusion dependent, bone marrow transplant is definitive, but because 70% patients lack a suitable donor, 2/3 patients on immunosuppressive therapy become transfusion independent. So it holds a very poor prognosis. But now because of the newer agents like thymogam, which is an immunosuppressive agent, 2/3 of the patient become transfusion independent. So unexplained anemia, gastrointestinal, is cancer of the stomach and colons. True local blood may be positive, but because of episodic bleed, it may be negative. Right-sided colon cancers are usually missed because sometimes they have episodic bleed, and the stool occult blood may be positive sometimes and negative the other times, and you miss a right-sided colon cancer. Usually patients present with weight loss, fatigue, gastric ulcers and ulcerative colitis, they have chronic bleeds, and sometimes we don't really know what is the cause of anemia, and you do an endoscopy, upper GI endoscopy or a lower GI endoscopy, and you find out there was a bleeding ulcer or there was ulcerative colitis. So anemia in the elderly patients, it is very important to know because most of our patients are geriatric population. So it is very important to know what is the cause of unexplained anemia in the elderly patients. So because of the dentures, they have nutritional problem. Also age-related achlorhydria. So age-related because there is fall in the hydrochloric acid level, and HCl is very important for the absorption of iron. Age decline in the intrinsic factor, because intrinsic factor forms a very important hormone for the absorption of B12. So age-related decline in intrinsic factor. Age-related decline in renal function, so there is low erythropoietin level. Chronic inflammation, as I've already told you, that chronic inflammation causes increase in the hepcidin level. So what happens is when the hepcidin level increases, the low absorption of iron from the small intestine, which causes anemia. Stem cell aging, as there is cataract, graying of the hair, you have osteoporosis. Similarly, the stem cells also undergo aging. And because of stem cell aging, there is decline in the erythropoiesis, which causes anemia. The androgen decline. In the female, there is ovarian function decline. In the males, there is testosterone decline. And androgen forms a very important hormone for erythropoiesis. So as a person ages, especially after the age of 75, there is significant androgen decline which causes anemia. Usually geriatric patients are on long-term NSAID abuse, allopurinol, PPIs, furosemide, metformin, phenothiazines, which are causes of drug-induced anemia. So what is the take-home message? The take-home message is that it is not only the CBC which is important. It is the peripheral smear examination, because peripheral smear examination will tell you whether there are blasts to rule out leukemia. If you are seeing fragmentation or cystocytes, you will see it is hemolytic anemia. So, and also aplastic anemia, you will see MDS, you will see macrocytic type of picture. So it is very important for the peripheral smear examination. The retic count, it is a most sensitive indicator of anemia. So if there is a high retic count, it is suggestive of either hemolysis or blood loss. If it is a low retic count, then you have to undergo, the patient has to undergo all the hormonal study, renal function test, liver function test, and if there is low serum iron and high ferritin, then it is more suggestive of anemia of chronic disease. LDH and ESR are more significant of LDH for B12 deficiency, hemolysis, ESR some chronic disease, LFT, RFT, thyroid studies, bone marrow study to rule out aplastic anemia, leukemia, PT, APTT, D dimer when you are suspecting microangiopathic hemolytic anemia, urinary hemosiderin to rule out paroxysmal nocturnal hemoglobinuria. And this is my last slide. He is very close to my heart, my dog, Simbu. He also developed anemia. So what happened is that the cause of anemia in my dog was worm infestation. So in our part of the subcontinent, even we have to look for parasitic infestation to rule out the cause of unexplained anemia. So we have to keep our not only eyes open, but we have to keep the windows of our brain open to know what are we dealing with when we have a patient of anemia. Thank you so much.
Thank you, ma'am. Any questions from the audience?
Hello, ma'am. It was a nice talk. To add on this dog incidents, I would like to add on something. And in most of the iron deficiency case, we see normally 8 to 10% of eosinophils. And CBC shows microcytic hypochromic with 8 to 10% of eosinophil. I urge each and every consultant to go to have a suspicion for the parasites and to have a worm albendazole treatment, because this worm can be a reason for the microcytic hypochromic anemia also.
Yeah,
So
very true.
we should suspect the worm infestation.
Yeah, so in our part of the subcontinent, because we advise the patient to undergo, especially the pediatric population, to undergo deworming. But even in the adult, we have seen that this could be one of the cause of anemia.
Thank you.
Ma'am, hello. Hello. Cost of the immunosuppression therapy in aplastic anemia in pediatric age group usually?
So, it is according to the body weight. It is 40 milligram per kg body weight for 4 days. So, it is, if your pediatric patient is say 10 kg or 15 kg, then it is comes to around 2 lakh rupees. And there is a support program also from the government for such patients, especially pediatric patient. I had treated a pediatric patient of aplastic anemia who was adopted at the age of 6 years. and he was to undergo a transplant at Karamsad, but unfortunately he didn't have a match because he was adopted. The parents did not know who the brother and sister were, so we gave him, the child came from Anand, and we gave him thymogam, and the patient achieved a complete remission in 3 months. But because, see, thymogam or anti-thymocyte globulin, it acts on the B cells. So you have to wait for at least 3 months to get a response.
Any age related specification can only this age group is usually respond with the immunosuppression therapy, or any age group we can
No,
take?
you can give it in any age group, but because it is made from horse or rabbit serum, the only thing is that you have to be very careful about the hypersensitivity reactions.
Thank you, ma'am.
Madam, can I add one more thing? Like malaria infection can cause anemia also.
Yeah, of course.
Yeah.
Yeah, even dengue can cause anemia. Any hemorrhagic fever can cause anemia. Yes.
Chronic malarial infections.
Yes, absolutely.
Thank you.
So according to a specific study done on 8,000 individuals in US, those who sit for more than 13 hours per day has 200% greater risk of death as compared to those who sit less than 11 hours per day. Imagine the power of 2 hours of standing up. So let's stand up and give a big round of applause to Dr. Vibhana, ma'am. I also welcome Madam down the stage for the felicitation. I request Dr. Vipul Gandharva to present the memento to Vima Madam. I also welcome all the chairpersons down the stage for felicitation. I request Dr. Jasmine Jasani, Dr. Dinesh Wagela and Dr. Denik Savani to present the memento to chairpersons. There is an announcement. All the delegates who have registered as registration committee members and patrons are requested to collect their special gift from poster presentation area just right side of this main hall of Lileria Banquet after signing the sheet between 11 a.m. to 1 p.m. There is another announcement. Recreational activities and fun games are going on outside of this hall for spouses and children, not for delegates. Delegates are requested here. So all the spouses and children can go and have recreational activities. To chair the next session, I invite Dr. Rajesh Salvi, Dr. Bhupendra Kapadia and Dr. Rahul Parmar on the stage. Dr. Rajesh Salvi is the consultant obstetrician and gynecologist. Dr. Bhupendra Kapadia is practicing pediatrician and current secretary IMA Vadodara. And Dr. Rahul Parmar is associate professor in PSM at Medical College Vadodara and our sports secretary of IMA Vadodara. Now I welcome Dr. Maulik Vaja sir on the stage for his talk on intracranial bleed, case-based discussion. And I request the chairperson to introduce sir.
It gives me an immense pleasure, more than an honor, to introduce my senior cum friend, Dr. Maulik Vaja. He is very humble, highly skilled, having razor sharp knowledge and having laser sharp focus while doing surgeries. He is awarded with fellowship in spine surgery, epilepsy surgery and skull-based surgery under renowned national faculty, Professor Dr. Manas Panigrahi. He is a specialist in different neurosurgeries of brain and spine disorders and is an expert in microvascular surgery, brain and spinal cord tumors, skull-based surgery and spinal disorder surgery, pediatric neurosurgery, cranial endoscopy, epilepsy surgery. Sir, stage is yours.
Yes, thank you everyone. First of all, I would like to congratulate all IMA team for organizing such a wonderful event and gave us the platform, and welcome everyone to Sanskari Nagari Vadodara. So my today's talk is about spontaneous intracerebral bleed, case-based discussion. The goal of these presentation is to incept and thought process about etiology and underlying causes for intracerebral bleed. So as we all know, intracerebral hemorrhage is hemorrhage within the brain parenchyma. Previously it was known as hypertensive hemorrhage. It is second most common form of stroke, but it is very deadly. Approximately 20 to 15 cases per lakh per year, and the incidence is increasing as the longevity is increasing. Survival is increasing because of advancement in medical practice. The volume of hematoma correlates highly with morbidity and mortality. Diagnosis and management is a medical emergency because ICH enlarge is in more than 33% within few hours of onset of hemorrhage, where first 20% occurs at the home and 15 to 20% of the deterioration happens after reaching hospital. So when we see hypertensive hemorrhage, it can be acute hypertension or chronic hypertension. Acute hypertension mostly due to eclampsia or drug induced while giving high dose of ionotropes and all that, whereas chronic hypertension, as all we know, because of chronic degenerative vascular changes in the brain. So common location of hypertensive bleed are the basal ganglia, where the putamen is the most common, followed by thalamus, pons and cerebellum. So this is a classical representative image of a CT scan. I would like everyone to just keep this image in mind, so you can correlate with subsequent images, where this is the image of classical putamen hemorrhage with different size. This is a hemorrhage in the thalamus, this is a pontine hemorrhage, and this is cerebellar bleed. So now we come to hypertension as a cause. So I just want to correlate with a general surgical situation, where previously we used to tell among surgeons that abdomen is a magic box, but at that time there were limited evaluation tools were available. But nowadays it doesn't surprises us much, because we have CT scan, MRI and lots of other evaluation techniques. Similarly, all ICH is not hypertensive. Other causes contributes 10 to 32% of spontaneous ICH. 35% of classical basal ganglia hemorrhage have underlying cause when it is in young patient, and many a times a patient who is not hypertensive previously comes with the high blood pressure because of Cushing's triad and raised ICP. So I would like to show you some example cases. Here is a 21-year female. When you see and superficial look of this CT scan, if you see, she had a convulsion followed by head stuck with the floor, and she brought as a head injury. Here there is a skull fracture you can see, but when you see this hematoma, there is some calcification within the hemorrhage. So when we evaluate these kind of cases, it can surprise us. By CT angiography, you can see there is a large interhemispheric AV malformation, and which is treated surgically by excision of AV malformation. Post-operative CT scan FVC, there is complete removal of the AVM and a healthy post-operative outcome at the end of 3 months or 6 months. So if this girl would have been overlooked by CT scan as a head injury, she might have a life risk if goes undiagnosed, and there can be rebleeding. Similarly, if you see this image, if you classically see, this is a hypothalamic bleed with intraventricular extension, but because of young age she was evaluated. So when we evaluate with DSA, you can see there is a PCA territory branch AV malformation. Now AV malformation is not a very common disease, but when it is come to young patient, we have to evaluate in detail to prevent the as it is a preventable cause of death. So because inaccessible and deep location, she was treated by radiation, and at the end of 18 months she was devoid of disease. So what are the pearls? So it ruptures in around 4 decades, but sometimes it may be early. Outcome may be more benign if treated and diagnosed timely. It is classified by its different location and size, and main modalities are surgery, endovascular embolization and radiation, and any combination of these three can be used when it is complex, and common complications are rebleed and flow related aneurysm. Similarly, this is a case of lobar hemorrhage. Now you see superficial look of this CT, you can see there is some bleed into the lobe, but it is not at the classical location of basal ganglia or thalamus. So when we evaluate such cases, there is a posterior communicating artery aneurysm which is clipped successfully along with the evacuation of hematoma, and outcome is in front of us and it can surprise us. So pearls are that prognosis of aneurysmal bleed depends on size and amount of SH, usually ruptures in 5th decade. Stable patient can deteriorate if undiagnosed and suboptimally treated, and common modalities are surgical and endovascular. Detail I would not like to tell, because if we discuss it can take 2 or 3 days CME, but the complications are rebleeding, vasospasm, delayed ischemic neurological deficit, electrolyte disturbance and hydrocephalus. But the most common any complication any neurosurgeon come across in case of aneurysm is vasospasm. So here is an example case, such classical case with lobar hematoma and subarachnoid hemorrhage, conventionally treated with surgery and aneurysm clipping. But patient may deteriorate even after good surgery. So there is a dictum among neurosurgery that all surgeries, the outcome is proportional to surgical performance, but in an aneurysm the outcome is irrational with the performance of surgery, because vasospasm is related with hemorrhage. So this is an example case where a vasospasm has occurred. This is a pre-angiogram image, whereas post the vasodilator image, you can see definite increased vascularity in the both the side, right and left ICA circulation. So what are the important things? So vasospasm can be aggressively treated by hypertensive therapy, chemical angiography and angioplasty, and sometimes balloon angioplasty. If this aneurysm gets undetected and vasospasm develops, survival becomes difficult, because the treatment of vasospasm is hypertension, which is strict contraindication when the aneurysm is unsecured. So this is the outcome. Similarly, neoplasm also can surprise us. This is another similar CT with putaminal bleed or caudate nucleus bleed, where the patient is a hypertensive, irregular on treatment, and eventually if taken as a hypertensive bleed, you can see the outcome. There is at the end of 3 months, she had initially she had herniation, bony decompression done, hematoma was not evacuated according to stitch trial, but at the end of 3 months post-op MRI, you can see the large tumor in the same area where there was bleeding. So eventually, because she was young, she was operated by re-exploration and excision of tumor, and at the end of treatment of lymphoma by chemotherapy, you can see the complete radiological response, and this is a gliotic cavity. So neoplasm also can survive. Similarly, many tumors can bleed. It can bleed in any way, like ICH, subarachnoid hemorrhage, intraventricular bleed, subdural hemorrhage. Commonly it is presented in high-grade neoplasm like glioblastoma, lymphoma, metastatic disease, but sometimes benign tumors also can bleed, like meningioma, pituitary adenoma present with apoplexy, oligodendroglioma. So same as vaso-occlusive etiology. This image, when you see a 21-year male patient, here there is a lobar hematoma, but it is a patchy bleeding. You can see it is a scattered and extending into basal ganglia, and intraventricular extension is there. Now here the key factor is history. 21-year male patient was presented with 4 to 5 days headache. The symptoms were overlooked, and later on he developed altered sensorium because he had intracranial herniation and emergency surgery was required as it was life-saving. He could not evaluate it before surgery with other investigation, but intraoperatively we can see there is a thrombosed veins along the midline. These are the thrombosed veins. These are the classical picture of cerebral cortical venous sinus thrombosis. Later on it can further confirmed by MR venography, but if it is overlooked or undiagnosed as hypertensive treatment, the treatment between CSVT and hypertensive bleed is polar difference, because hypertensive hemorrhage can be managed conservatively, whereas venous sinus thrombosis patient needs anticoagulant treatment. So we don't give anticoagulant in classical hypertensive bleed, but here it is the mere indication. So post-operative 6-week CT, if you see, the hemorrhage is resolved, and at the end of 4 months the bone flap was replaced and a healthy patient without any neurological deficit was there. So similarly, other common causes neurosurgeon come across are cavernoma, coagulation or clotting disorder, CNS infection, alcoholic liver disease, dural AV fistula, pregnancy-induced eclampsia, idiopathic post-operative bleed, and sometimes a trauma where the exact event or witness is not available. Trauma, it can be taken as a hypertensive bleed, but trauma was the etiology. So to understand these, the key factor is starting with the detailed history checklist. Now why history checklist is available? Because many a time as a neurosurgeon, we get, because of availability of WhatsApp, we get lot of WhatsApp reports કે સર આ જરાક જોઈ લેજો ને આ એક રિપોર્ટ મોકલ્યો છે, આપણું પેશન્ટ એક છે મોરબી, સુરેન્દ્રનગર, ભાવનગર, something like that. So if the report is only read and patient history or detailed event, sequence of event is not evaluated, you may be misguided. Similarly, the first imaging of choice is CT scan, whereas MRI is not investigation of choice. Now we know the initial management as A, B, C, D. A, B, C, D we know, but I would like to focus on the point that basal ganglia or cerebellar bleed patient doesn't need anticonvulsant prophylactically. If and at all they develop convulsion, then only we give anticonvulsant. And second most common misconception is giving steroid. Many physician or a clinician give steroid in case of hypertensive bleed. So I would like to stress upon that we see the type of edema and then we treat it. If it is cytotoxic edema, we treat it with hypertonic saline or mannitol. But in case of vasogenic edema, steroid is required. So steroid is only recommended in case of underlying neoplasm, because hypertensive bleed or spontaneous ICH without underlying neoplasm is having cytotoxic edema which is not responding steroid, and it is strictly contraindicated. It is having level 3 evidence in Brain Trauma Foundation protocol. So I would like to remember this point for everyone. So why to do radiological evaluation? As I told you, we should not, nowadays we see hypertension in young patients, but we should not take it for granted that hypertension is a cause and all the bleed occurs due to hypertension, and we have to rule out other underlying etiology, and for that CT angio is routinely we do for vascular lesion, but DSA, digital angiography is gold standard. So the indications are young age, no hypertension, lobar hemorrhage, subarachnoid hemorrhage or IVH associated with intracerebral bleed, isolated intraventricular bleed. But angiography we routinely not recommend in combination of 3 situations where the patient is more than 45 years, having pre-existing hypertension and classical location of bleed, but this is not the rule of thumb. We have get surprised sometimes with the underlying pathology. MR angio is not recommended because it is having only 90% sensitivity for vascular pathology. Many a time tiny aneurysm or concealed AV malformation can be missed in MRI. MRI is only recommended in the follow-up cases where we do not operate the patient. The hematoma may be turned out due to underlying neoplasm. So neoplasm, if there is a classical principle that if the hematoma resolves over a period of 3 months, if it is a neoplasm, it will progress. So on follow-up MRI, we can get complete idea whether that bleeding was a neoplasm or a classical hemorrhage. And MR venography is investigation of choice for cerebral sinus thrombosis. So recommendation for non-surgical management, each ICH evacuation doesn't need evacuation in early stages as it is recommended in stitch trial. alert patient with good GC scale. Small clot less than 10 cc does not need evacuation. Little chance of good outcome like very advanced age, massive hemorrhage, large hematoma, dominant hemisphere bleed, poor neurological condition where GC scale is very poor, and patient present after 24 hours of deterioration. Along with that, severe coagulopathy and deep-seated hemorrhages are not recommended for surgical management according to Stitch trial. So we have a very good guideline. ICH score is available. It is available everywhere in online, where it is conclusively take 5 different points, and as a score, if you can see, the higher the score, higher the 30-day mortality. So we can calculate and judge. Every situation is different, whether to operate the patient or not on the basis of ICH scoring. So recommendation of surgical management. Deteriorating patient with herniation considered as a life-saving surgery. Every case there is a economical, financial, emotional and family decision is there, so we cannot make a rule of thumb when to operate and not. Large clots like more than 30 cc with significant midline shift need surgery. Now how to check the volume of clot? So you need not have to check any formula. Your CT technician or radiologist can easily calculate with a very simple method and tell you how big is the hematoma. The favorable outcome like lobar hematoma after exclusion of underlying pathology can be operated. Cerebellar bleed have excellent outcome where there is no involvement of cognition on long track. External capsule bleed, non-dominant hemisphere hemorrhage in young patients who can tolerate surgery better, and underlying suspected secondary cause. So what is take-home message? So every ICH is not hypertensive ICH. Though hypertensive ICH second most common cause of stroke, it is deadlier than a ischemic stroke. Other than hypertension, there are 10 to 30% patients who have other causes than hypertension. Hypertension is not a cause in at least 35% of patients who present with classical CT scan finding of hypertensive bleed. Lobar hemorrhage have a more benign outcome compared to hypertensive hemorrhage, and detailed history checklist, sequence of events, proper radiological evaluation, definite protocol of monitoring and follow-up is required rather than just focusing on hypertension as a cause. Thank you. And as we all as a medical fraternity, we stood tall in the time of COVID. I pray and hope that we will stand tall always and we get inspiration from our dear Sardar Vallabhbhai Patel. Thank you.
Any question from audience? Mike.
Congrats, Maulik.
Sir.
Excellent presentation.
Thank you, sir.
Just one humble question. Newborn with a sacral meningocele, with a MRI spine reporting as a tethered cord. So when to intervene or when not to intervene? What is your kind suggestion?
Sir, thank you. Though our topic is not on that, I would like to definitely solve your query. So meningomyelocele is a very vast topic. It cannot be answered in a one sentence or in some time, this time. So first and foremost, if it is open rupture defect with neurological involvement like paraparesis, I would personally feel, though literature may differ, I would personally recommend not to treat this kind of patient because it is financial and emotional burden to the family. These kind of patient develop very bad consequences in terms of meningitis, critical condition. So if there is a destiny for this patient to survive, you can operate this patient at the end of 3 months or 6 months where patient is able to tolerate this surgery. Thank you.
A spine surgeon would be happiest if we upload his talk with a straight spine. So let's get up and give him a big round of applause. Thank you, Dr. Maulik sir, for an excellent talk. Now I welcome you down the stage for the felicitation. I request Dr. Bhupendra Kapadia to present the memento to sir.
Now I welcome Dr. Archana Dwivedi ma'am on the stage
for her talk on contraceptive pills. Let's revisit. And I request the chairperson to introduce Madam.
Hello. Good morning, everybody. As we know, yesterday, Dr. Deepak Jumani sir has given one wonderful lecture on management of male erectile dysfunction. Everybody enjoyed? Yes? Now, if that treatment gets affected, then the female partner will require some important medicine in the form of contraceptive pills, isn't it? If the treatment of male erectile dysfunction is egg, then the counterpart will always require some medicine, that is the contraceptive pill. So today, Dr. Archana Madam, she is a well-known gynecologist of Baroda, and she has a key interest in high-risk pregnancy, laparoscopy, vaginal surgery, non-descent vaginal hysterectomy, faculty for adolescent counseling and menstrual hygiene awareness and anemia eradication program in School of VADODARA and Periphery, faculty at various national and international conferences, winner of Jagdishwari Mishra Award at ISOPAB and Gujarat Gynec Excellent Award at UA Foxy 2020 Ahmedabad. So many other feathers are there in Madam's basket. So I would like to hand over to Madam, please.
Thank you, sir, for the kind words, and I am really thankful that you mentioned Dr. Jumani's lecture, and I would like to congratulate team Gimacon for excellent exhibit of this scientific, and yesterday we had a good fun extravaganza also. So thank you for making me the part of this academic extravaganza, and let me tell you that we should not underestimate the power of a common general physician, because this is the topic which is very close to my heart and very, I would say, basic topic, where we have patients who are really worried what to start. Pre-marriage and post-marriage, we have got so many people confused about the contraception part. So here, as a disclaimer, I would say that we support only scientific discussion and evidence-based medicine. So through my slides, I'll be taking you to these 6 points, starting from the recommendations, counseling, and to the missed pills, and even to the emergency contraceptions. So why are we talking about contraception? Because it's a need of the hour. Unwanted pregnancy is a burden to the social and economic status of the patient and the family. And let me tell you, if unmet need for contraception was met, we can avoid 55 million of unwanted pregnancies, 22 million fewer abortions, 90,000 fewer maternal deaths, and safe abortion practices. As we know, there's always a loophole. So we are also doing something for the mankind and the women empowerment. So talking about the prevalence, as you can say, 15% of currently married women aged 15 to 19 years use a contraceptive method, but largely there are adolescent people who are really not educated about what is contraception, so they need to be targeted and to be counseled properly for that. So now we are going to discuss what are the common factors which prevent and how we overcome that. Key factors which influence the unmet need of family planning is that the age of marriage, the education, the interspousal communication, fear of side effects of contraceptive, and the number of living children. So let me tell you that about 4.1% of women prefer contraceptive pill for contraception, so lesser amount. And this is the effectiveness of family planning methods, if you see, which is starting from the spermicidal jelly to the most effective permanent sterilization. We are placed in a very proper situation when we are prescribing a COC to our patients, where there is 9% and 99.9% accuracy when we give a contraceptive purpose. So the most frequent reasons why we select hormonal contraceptive methods is it is easy to use. Pop-up pill is very easy. Progesterone only pill in the breastfeeding. So this is a whole basket. Vaginal ring when patient wants its convenience, and long acting we have LNG IUS, and convenience 3 monthly use we have got injections. Restricting my talk to the hormonal contraceptives, we have got this type of basket in which we have combined pills, progesterone only pills, long acting and emergency. The combined pills have monophasic, biphasic, triphasic and quadriphasic, unfortunately, which is not available in India. Whatever you choose according to your patients from this basket, remember we are trying to help them to meet their needs of unmet pregnancy. There are other benefits also when we are offering to our patients when we give the contraceptive measures. The benefit to the mother is that it reduces the need of abortion, especially unsafe abortion, prevents pregnancy-related health risks to the women, and prevents death of mothers, and the children neonatal outcome is very good. Bhupendra will agree with us. And benefit to the family is that right to determine the number and the spacing of the children remains with the women itself, and it also slows the population point. So the effective counseling is very, very important. We should give the whole basket to our patient, give her the choice to select from that, and the continuation is also very, very important because it's a reliable method. And the only one thing is that this, it doesn't prevent against STD, so we have to additional advise condoms when we are prescribing the COCs to the adolescent or the unmarried women or the partner suffering from any STDs. So when we have a structured counseling for the patient, you can see 89.6% choose hormonal contraceptives. So coming from 4% to 89% is a very good thing. So here it's our role to do a proper counseling so that we have proper use of the COCs and we are productive to the society as well. So 40.7% patient after the contraceptive counseling choose COCs as a method. Coming to the recommendation, we should do the initial workup, and it only requires to measure the blood pressure. That is the only part, and otherwise any history of migraine, epilepsy, baseline body weight, body mass index should be always recorded because the most common problem which patient states us is gaining weight. Pelvic examination, Pap test, screening for sexually transmitted diseases cannot be replaced when we are prescribing COCs. So, guiding principles if we talk about it, lowest dose of estrogen and progesterone is well tolerated with a good safety profile, and additional non-contraceptive benefits give us a proper choice for the patient. So, less than 40 years patients, the MEC recommendations are for less than 40 and more than 40 years. More than 40 years usually can go for COCs, and women again menarche through the reproductive age can also be prescribed without any restriction. Only when we talk about above 50, we have to be very restricted. So coming to this very beautiful chart, I would say if we talk about the adolescents who are the high risk, give them a COC option. They do have bleeding irregularities, intermenstrual problems are there, irregular cycles. So proper counseling and giving the COCs can help them for the non-contraceptive benefits also. Reproductive age group, you are preventing the patient from having unsafe abortion, relieving her of PID, reducing the risk of ectopic pregnancy, higher hemoglobin and ferritin levels are there, no evidence of chromosomal abnormalities is seen, and no evidence of masculinity in the female fetus. Women above 35 years, the benefits of oral contraceptive usually exceeds the risk because this is the time, sometimes the infertility patients when they are above 35, we see they conceive spontaneously. So there the COCs are very, very important because additional benefit again suffering from menorrhagia, suffering from bleeding problems, they are helped. Regarding the perimenopausal phase, we have to be very judicious when we are prescribing because there is a term known as MHT, where we prescribe the hormone therapy to the women before age of 55 so that they have additional risk of prevention against the cardiac, the osteoporosis, and there are so many other things also. So it is very, very important, and even the reduction of acne and the overlapping problem of PCOS. So we have a benefits of COCs in reducing the menstrual cramp, preventing the ovarian cyst formation, prevents against the endometrial and the ovarian cancer. It also prevents pelvic inflammatory diseases and reduces the excess body hair where you can see the PCOD patients, hirsutism patients, and also relieves the symptoms of endometriosis. Nowadays we have got variety of pills in which we are combining the Dinogest along with progestin so that the endometriosis can also be dealt very nicely with a very economical package of COCs. So this is the whole development where the amount of estrogen and progesterone was to be decided, and the mechanism of action is they stabilize the endometrium, they prevent ovulation, the progestin part makes the endometrium hostile. It doesn't favor implantation, and also there is a suppression of negative feedback effect on the hypothalamus, and it also increases the SHBG and facilitates the metabolic clearance of the testosterone, so that decreasing the free androgen index. So now we know that before screening we need to have basic line test. So how do you initiate? As I already discussed, that blood pressure, baseline weight and pelvic examination. There are two components when we talk about the estrogen and the progesterone component. Estrogen is very potent and more liable to cause side effects. So the making of the endometrium less suitable for implantation, desudalization and eventual atrophy is occurring because of this. Progestin component which we add with estrogen in that, there is thickening of the cervical mucus and impairment of normal. This is very important. The tube motility is also affected, so the egg doesn't pass into the tube so easily. So these are the types of progesterones we have started from first generation to fourth generation. Let me tell you, third generation is giving us a very much beneficial effect, which I'll come in the later slides. Remember, all progestins are not equal. It is potency which is important, androgenic, anti-androgenic property and anti-mineralocorticoid, and decreasing the SHBG binding is very, very important. So when we compare the older progestins to the newer progestins, the third generation desogestrel is less androgenic, negligible impact on the carbohydrate and lipid metabolism, and potent inhibitor of ovulation. So low estrogen doses combined with this and can be used in the treatment of acne and hirsutism. This is the basket which we get in India, out of which, as I told you, EE and Dinogest is what we are using for endometriosis treatment. So third generation, when we compare with the other, preferred because there is a lower discontinuation rate, lower intermenstrual bleeding, and also when we talk about it, the continuation is very important because of this other side effects which are coming, like the weight gain, the nausea, the vomitings and the migraines. So this has got a better safety profile because of its less anti-androgenic properties. So these are the dosing regimes which we follow. Biphasic pills, there is monophasic, multiphasic, cyclic use and continuous use. Here I would like to tell you cyclic use, what does it mean? 21 days of pills, 7 days pill free period. 24 days of pills and 4 days regime. These are two things we are following. And continuations, like you keep on giving it, say for 2 months you could give an extended regime also. So when we talk about cyclical pill packets, the 21-7 is more preferred because hormone-free 7, in between they have the bleeding and then they can recontinue the treatment part again. So the benefits is that the fewer 21-7 regimes results in less unscheduled bleeding and more scheduled bleeding when we compare with 24/4, because there's only 4 days of pill free. Somebody may have the periods immediately after stopping, some may take some more time. So this is the evolution which has taken up, and gradually the dose of, now talking about the estrogen, which is another important component of the progesterone pills. The high dose to the low dose, why we have moved? Because we want to reduce the risk of VTE, lower the estrogenic adverse events, and better safety and reliability. So the era of ultra low dose pills have come now, where the combination of 20 micrograms of ethinyl estradiol with 150 desogestrel, and these formulations are very easily available in the market with a low cost, and it also contains a very good acceptability by the patient with least side effects, along with good tolerance and good continuation rate also. There is less incidence of acne, so most of the dermatologists also prefer giving to our patient to have a beautiful skin, and especially premarital, if you give them, the ladies are very, very happy because there's a skin texture also improves, less of acne, less of hirsutism for the patient. And it has got led more often to ovarian follicle cyst as compared to the high dose of COCs, where retention follicle was a problem. And when we talk about the tolerability, as I said, it is well accepted because there is a good cycle control, no clinical evidence of weight gain, and minimal chances of increase in blood pressure. So it is good for our patient friendly, I would say. A step further, we have got ultra dose pills. So whosoever comes to us as a first time users of contraception, most commonly we see people having barrier contraception, but if we counsel them, they choose for the oral contraception, and it assists the patients to plan their families As I said, unmet pregnancies are a difficult problem. When we talk about comparison between the barrier and the oral contraception, you can see it is a proper use of oral contraception to our patient, gives us the non-contraceptive benefits, spacing is there, they can plan their vacation, they can always schedule. Bleeding is very, very important punchline in these patients, and prevention of ectopic pregnancy. So when a 23-year-old married lady comes to us who has never used a contraceptive pill, we are having a basket to offer to her because she's a newly married lady with a first-time user. And there is a patient who is lean but still worried that I may have a weight gain, but she wants to delay her pregnancy. So this is the right time to prescribe her the COCs, because less of the side effects will help us. So when to start? Up to including day 5. I would recommend day 2 because 48 hours the endometrium needs to be regenerated. And if the patient forgets the pill, I'll come to that daily. If you have started within the 7 days, ask her to use some barrier contraceptive till 7 days, and then she can continue with the whole dose. Coming to the women who are postpartum, single daily use of progesterone only pills is a very good option for them. And even the post-abortion patients also we can prescribe the COCs. So start with the low effective dose, and remember it is not it has to be patient friendly, and we have to counsel our patient and decide the dose and the contraceptive method according to their need. So ultra low dose is a good evolution which is going to stay with us, and the first time users of the pill switchers, ultra low dose pill is a good option which is available. So it can be used for as long as 50 years without any difficulty in conceiving. As soon as the patient stops, they can conceive immediately. Coming to the word about the missed pill, see, once you have missed the pill, continue the contraceptive efficacy, but within 7 days of missing the pill, if you have missed once, take it as soon as you remember, take it, and then continue with the other dose as you were taking. But if you have forgotten more than 1 or 2 doses, use barrier methods for 7 days and then continue with the dose of the pill and finish it on. It minimizes the pregnancy risk. Pills missed in first week, consider emergency contraception if unprotected risk. Pills missed in the second week, no need of emergency contraception. If the pills is missed in the third week, omit pill free interval and start next pack after finishing the active pills in the current pack. That is the take home message. A little word about the emergency contraception. We have been using SUG practice bulletin 69 says taking a dose as soon as possible increases its efficacy. There are few things which are available: progesterone only, mifepristone. Estrogens have also been given, IUDs have been inserted. Progesterone only pill, the UP's regime was very, very common. Within 72 hours, take the pill, which is 0.75 levonorgestrel, and it inhibits again the same progesterogenic effects are there. It becomes hostile to the cervical mucus, and single dose is enough nowadays, which is available. Copper T is also a good option which is available. Mifepristone low dose can also be given. But now the new thing in the market is ulipristol. It is a selective progesterone receptor modulator which is FDA approved, available in India with little bit of side effects, but single 30 milligram tablet within 120 hours. So it gives us a more range of time when we talk about for the unprotected intercourse, and it is an effective emergency contraceptive method, can be used within 120 hours. That is its USP. So that is very, very important. Pregnancy within the use of 72 hours, if you see. LNG group, we have 2.6%, and Uripristal, it has got a better efficacy by 1.8. So the key message I would like to summarize it, like in India, the average rate of modern contraceptive use is very low, so effective counseling can help our patients to select the contraception. For the women of age groups 21 to 30 and 31 to 40 years, COCs are the most frequently chosen method, and combination of 20 EE with 150 micrograms of desogestil, that is the low dose pill with a third generation progesterone, is very effective, well tolerated, and maximum continuation rate. So benefits, we should not forget that some women take pill also for the health purpose. The pill can regulate or lighten the menstruation. It prevents anemia, as Viva madam talked very nicely about it. It lessens the menstrual cramp and manages the premenstrual syndrome, which is very much common. Premenstrual syndrome or the premenstrual disorders are there. It also treats the polycystic ovarian disease, treats endometriosis and fibroids. It lowers the risk of ovarian cancer, uterine cancer and colon cancer, stops the unwanted hair growth, reduces migraine. So remember that it is not that migraine is always a contraindication. Now with the low dose, ultra low dose, it can be given. It controls the hot flushes and gives a slow transition into the menopause. So thank you so much for this opportunity, Gimacon team. I'm very happy to share my views on contraceptive pills at this point of time. Any questions I would like to?
No questions.
Yeah. I would just like to end up by saying that nowadays people come with a mobile apparatus that I know when I'm going to ovulate and when I'm going to. So this is a very difficult thing which is coming up when we talk about the counseling. So I think mobile savvy patients would need more time of our counseling. Dr. Rajendra would agree, because COCs are a better option in terms of meeting the target of unwanted pregnancies. Thank you so much.
We are into the 6th lecture of today, and to improve moods, energy and blood circulation, let's stand up and clap for Dr. Archana Madam. Thank you, Madam, for your excellent talk. Now I welcome you down the stage for the felicitation. I request Dr. Rajesh Salvi sir to present the memento to Madam. Now I welcome Dr. Sonia Dalal Madam on the stage for a talk on newer advances in interventional pulmonology. And I request the chairperson to introduce Dr. Sonia Dalal ma'am.
Dr. Sonia Dalal, a great academician who has published many papers, and out of that few are health-seeking behavior among TB patients in rural Maharashtra, lung injury in tropical lung disease in India, trend of obstructive sleep apnea in Indian males. In 2008, she has been conferred a fellowship by the American College of Chest Physicians. She has presented posters on asthma and COPD at European Respiratory Congress. And in 2013, she has been invited as a faculty at the chest conference by ACCP at Chicago. And one more introduction by my one of the grandparent. મેડમ એટલે હું પહેલાં નહોતો ઓળખતો, તો મેડમ એટલે કોણ? તો દાદીએ મને એવું કીધું, મેડમ એટલે એકદમ તીખું મરચું. જો એમણે લખેલી દવા ના લઈએ એટલે ફાઇલ ફેંકી જ દે. પણ મેડમ બહુ સારા. મેં કીધું આમ તીખું મરચું અને આમ બહુ સારા? તો એણે એવું કીધું કે મારા ઘરવાળા બહુ ગભરાય, મેડમથી બહુ ગભરાય, બીજા કોઈથી ના ગભરાય. અને એના લીધે મારી બધી દવાઓ એ યાદ રાખે. Thanks for increasing and maintaining bonding between couples. Over to you, madam.
Thank you so much, chairpersons, for a kind introduction. A big shout of thanks to the Gimacon for giving us an opportunity to present our cases, and I take a privilege, chairpersons, to take my colleague along with me. So he's going to discuss the cases since we have a lot of videos into that. Ladies and gentlemen, you all are aware that pulmonary branch has taken a striking presence in the last couple of years, especially after the pandemic. As we bask upon the arena of this interventional pulmonology, where we pulmonologists are very accurate in giving the diagnosis as well as the therapeutic approach when it comes to functioning into the lung, in the airways as well as the parenchyma. Of course, we know our limitations and we don't cross our domain with the cardiothoracic surgeons. So what we are now going to talk about is interventional pulmonology and all the procedures that we do at our hospital, that is Kalyan Hospital, Dalal Sleep and Chest Center. And I have a privilege of also introducing my colleague who works with me tirelessly, Dr. Abhinav Bhosle. So we all know, and you all might be aware, that whenever there is a patient, we send to a pulmonologist for a bronchoscopy, and these are the tailor-tested tests which are done, which is a bronchoalveolar lavage, which is going to give you a good diagnosis as far as the microbiology and as well as the cytology is concerned. Taking up an endobronchial biopsy when you want to prove a sarcoid, a granulomatous lung disease like a sarcoid or a tuberculosis, and of course a transbronchial biopsy in certain interstitial lung diseases. Abhinav, can you take on from this, please?
Thank you, ma'am, for the opportunity. So first case is a 78-year-old male. He had presented to us with cough, persistent cough post-COVID-19 pneumonia. This cough was persistent since 1 year, and on history, he had told us that he had been admitted 1 year back for renal stones. That time also he had this cough, dry cough. That time a CT scan was done which had shown a small cavity in the right upper lobe. Now, a repeat CT scan was done for his persistent cough, which was.
So the CT scan shows, if you have a look at it, there is, can I have a, yeah. So there is a big mass which is coming up from the right upper lobe and the middle lobe. If you look at the coronal sections as well, there is a big mass over here. He was a smoker. I mean, I'll show you the videos over here. We went through a bronchoscope inside, and this is the carina, and this is the left lung. If you go to the right side, on the right side there is a mass which is seen over here. From this mass, we took up a biopsy and we had sent it for investigation. We sent it for histopathology as well as we sent for the microbiology. When we took the biopsy, it turned out to be a poorly differentiated squamous cell carcinoma. And on in histochemistry, it proved that this is a primary which is from the lung.
So the second case,
I'll just finish. Ladies and gentlemen, we all know that the eating tube and the breathing tube are neighbors, right? So whenever you ingest something, by mistake, it probably pops up and goes into the breathing tube. So we are now going to talk about all those things which you want to ingest into the digestive tract, but go stuck up in the in the bronchial tubes. So Abhinav is now going to talk about two cases which is stuck into the bronchial tube.
So the first case is a nonagerian male, a 90-year-old male who had presented to the emergency department with cough and breathlessness at rest, severe breathlessness. So, and he had very severe wheeze also. On treating with nebulizations and bronchodilators and steroids also, there was no relief in his symptoms. And on probing history, he had been told he had told that he had swallowed some food particle. So on an HRCT scan which was done, it showed this.
So I'll show you a video and I'll stop where I'll show you there is a filling defect in the bronchus. This is the coronal sign. And if you look at it, there is a filling defect over here. If you can look at this is the left main bronchus and there is a filling defect. On an axial one as well, if you look at this, there is a filling defect which was, and classically, and if you look at the shape of it, this shape is never for a endobronchial mass or a carcinoid or anything that sort of. A nonagenarian is a 90-year-old gentleman would not have an endobronchial benign lesion like this, and he had a ingestion of a foreign body. We took him for bronchoscopy. In the bronchoscopy, in the paucity of the time, I'll run the video very fast. If you can see, there is a foreign body which is seen in the left main bronchus over here. Over here, it was very difficult for us to remove this. So what we used a toy called a cryoprobe. What does a cryoprobe do? It will touch on the level, on the foreign body, and it will freeze over there, form the snow plume, and that the foreign body gets attached to the cryoprobe, and the whole thing comes out in toto. So then the cryoprobe, we introduce the cryoprobe. The only thing is we have to remain into the center of the wherever we are working, because if it freezes to the bronchial walls, then probably there are all the chances of bleeding from the bronchial tubes. So when we went inside, we tried, and this was on a breathing patient. No anesthesia was given, it was only a conscious sedation, ladies and gentlemen, mind well. Patient 90-year-old, we have not intubated, we have not given any anesthesia. We put it, and when we touched the probe, it went to the heart side. And then we touched it on the left side, but touching the wall over here, we had to release this because it would bleed. And there is where the forming of the snow plume is there. The whole foreign body gets attached to the cryoprobe, and the whole thing comes out in toto, like this. And this is a dried mango which is made for the pickle. And we took the whole thing out, and the patient was absolutely fine. The post bronchoscopy, after the removal of the foreign body, there was a recanalization of the left main bronchus. This is a case 2.
So another 80-year-old male, he had a CA buccal mucosa, and he came to the emergency with severe breathlessness and cough and wheezing as well, and he had gross desaturation. In the emergency, on probing history, he had given a history that for his constipation, he had taken some Ayurvedic pill. Immediately an HRCT scan was done, which showed.
So when he came to me, he was having a saturation of 55%. He had taken a Trifla for his constipation. When we took him in the ICU and repeated we did a CT scan, there was a complete block of the right lower lobe bronchus. We took him for bronchoscopy, but problem was that the bronchoscope could not be passed because of a very small diameter of the upper airway because of the CA buccal mucosa. So we involved the oncosurgeon. What he did was he put in a retractor, opened up the mouth, and we put in the mouthpiece and we went through a bronchoscope. When we went in, if you look at the first, there was all slough over here with a lot of granulation tissues. We started cleaning up the stuff and we could see this trifla tablet over here. If you can appreciate my arrow over there, there's a trifla tablet. Again, we passed in the cryoprobe. Since this was an organic thing, it got stuck to the cryoprobe. We removed the whole of the trifla tablet and then we did the recanalization and we saved the life of the patient. So ladies and gentlemen, these are some of the toys that we use to remove the ingested foreign bodies. These are a double prong, a triple prong, a cryo or a forceps and the Dormia baskets. Some of the foreign bodies that I have removed in my lifetime is the teeth, a peanut, a dental burr and so on and so forth. Tissue is always an issue, ladies and gentlemen, when we take a transbronchial biopsy, because the size of the tissue when we take a transbronchial biopsy is 0.4 to 0.8 centimeters. And always there is a conflict between the pulmonologist and the pathologist about the size, because they cannot give a complete diagnosis on the basis of a transbronchial biopsy. Hence, we came up there with a new modality which is called a transbronchial cryobiopsy. We'll show you a case of that as well. Abhinav, fast.
So this was a 50-year-old male who was a diabetic and it was uncontrolled, and he had cough, breathlessness on exertion since past 2 months, and he had fever since 15 days. On X-ray, there were fibrotic opacities in the left upper and lower zone, and he had a history of tuberculosis, as I said in the past, and an HRCT scan was done for these fibrotic opacities, which showed.
So this was his HRCT, ladies and gentlemen. If you look at it, there is a big consolidation in the left upper lobe. He also has a bronchocentric reticular opacities, and also he had a lot of reticular opacities in the bases. So our diagnosis prima facie was maybe is infection with an interstitial lung disease, and since it was predominant cranial predominance, we thought probably we are dealing with hypersensitivity pneumonitis. We took him for a bronchoscopy. What we did was we intubated the patient with the intubation. First we introduced a Fogarty catheter because when we take a biopsy, there are all the chances of bleeding from the lung. So first we introduced the Fogarty catheter from the region where we are going to take the biopsy. Then we introduced the cryoprobe inside, and from there we took a biopsy. This is the cryoprobe which goes into the lung, and from here we have taken a biopsy, and then once the biopsy is taken, we inflate the Fogarty catheter to prevent the spilling of the blood to the other lobe or the other bronchopulmonary segment. And these are the sizes of the biopsy that, this is the size of the cryobiopsy that we got it compared to the smaller ones of the transbronchial. The size from the cryobiopsy is normally between 0.8 to 2.4 centimeters compared to a 0.1 to 0.4 centimeters of a transbronchial biopsy. The histopathology of, was suggestive of lymphocytic infiltration with granulomas which were scattered along with some giant cells, which was suggestive of chronic hypersensitivity pneumonitis, and the bulk that we took was suggestive of tuberculosis. When we combine a rigid bronchoscope and a fiber optic bronchoscope, which is called amalgamation of the rigid as well as the fiber optic, we can use modalities like the hot therapy as well as the cold therapy, that is, using up the APCs, the electrocautery as well as the cryo. So we now present with a debulking case where we are using a hot as well as the cold therapy.
So this was a 68-year-old female who presented with cough, chest pain and dyspnea. She was treated with antibiotics, antitussives and other symptomatic medications, but there was no relief of her cough. So a CT scan was done.
Her scan, if you can see on the sagittal section in the right upper lobe, there was a very nice, space occupying lesion like this, but the parenchyma was absolutely normal. If I show you the CT scan of this, if I run, if the video is playing, is it playing? Yeah, it is. Okay, there is a right upper lobe collapse completely, and then there is a mass over here in the right main bronchus. We did a bronchoscopy. What we did, we intubated with the rigid bronchoscope, passed in the fiber optic bronchoscope, and through the fiber optic bronchoscope, we passed the electrocautery snare. We went to the base of that lesion, and with that electrocautery, we cut the whole thing, and then what we did was all the sides of the walls, because it would bleed, we used the APC to stop the bleeding, and then we applied a cryoprobe and removed the whole lesion en toto. So this is the lesion. This is the electrocautery that I am passing through. If you can see, this is the electrocautery, it's burning. So I'm passing through the whole thing and going to the base, and with the electrocautery current, I'm going to cut the base of the lesion. So that's how we cut the base of the lesion. We apply the APC current to the wall so that we prevent the bleeding, apply the cryoprobe and remove the whole mass en toto. And this was how the recanalization of the airways were done. We took out the whole mass over here, and the histopathology was suggestive of lipoma. It is an endobronchial benign tumor which is endobronchial lipoma, and it relieved the patients of all the symptoms. Ladies and gentlemen, we come across a lot of pathology which is endobronchial as well as, in the parenchyma. But what about mediastinum? We also lead with, and we have probably now a toy which is called an endobronchial ultrasound, which has got a bronchoscope. Attached to that is an endobronchial ultrasound probe. So this is what we do beyond the walls, diagnosis of endobronchial pathology or pathologies beyond the walls. So this is the case of an EBUS. Abhinav, to you.
The first case was of EBUS is a 56-year-old male who had cough which was dry in nature, and he had hoarseness of voice as well. There was no fever. There was definitely weight loss and loss of appetite in this patient, and he was a smoker. So a CT scan which was already done showed.
The CT scan showed a right paratracheal big mass over here. We took him for the EBUS. So we pass the needle through, the endobronchial ultrasound is going to detect the mass, and we pass the needle through the bronchoscope, and this is the mass. We will pass the needle from there, and we took the tissues from there. If you can look at this, this is the needle which is passing through the mass. We take the sample from here, and we gave a this is the representative sample which came through the needle, and the diagnosis was adenocarcinoma. Case 2, please.
So the second case was a 67-year-old female. She had history of cough and fever since past 1 month, and she also had history of headache, for which even she was evaluated extensively, and CSF examination was also done, which was inconclusive. She had loss of weight and appetite, and her X-ray was normal. A CT scan which was done showed
station 7 and station 4R, that is right paratracheal lymph nodes and the subcarinal lymph nodes. Apparently this happens to be Dr. Neeraj's patient. We took the patient for the EBUS, and we took the sample from the station 7, that is subcarinal lymph node. This is where the needle is going from cortex to cortex, and we take the sample. It turned out to be granulomatous lung disease, and AFB stain of there was positive. Gene expert was positive. That was suggestive of mediastinal tuberculosis. Ladies and gentlemen, we all the pleural effusions in the lung in our country are not tuberculosis. Please remember this thing, and this should be a take-home message. So whenever you have an undiagnosed pleural effusion, we have this toy which is called a flexi-rigid thoracoscope, which can be used to work into the pleural cavity. So we have a case 1 from Abhinav.
The first case of thoracoscopy will be a 28-year-old female. She had fever and breathlessness on exertions in past 10 days, and an X-ray test revealed a left massive pleural effusion. 1500 ml of pleural fluid was tapped, which was sent for analysis. This was his her X-ray post tapping. The fluid was pretty inconclusive with ADA of 33 and all cultures negative. So a CT scan, so the patient was taken up for thoracoscopy.
When we took the patient for the thoracoscopy, we could see a lot of septas inside, along with lot of echogenicity, and the pleural fluid was straw colored. If you can look, these are all the septas. What we did was we passed in the forceps, and we took the biopsies from the septa. Septa also gives a good yield for the AFP. The gene expert in this was positive, and if you look at this, this is called a typical sago grain appearance of the parietal pleura of the tuberculosis. We broke all the septas, took biopsy from that, and then we also took the biopsy from the parietal pleura. Of course, we know our limitations, that we remain always on the parietal pleura side, and we don't go to a visceral pleura side, so we maintain the decorum of the cardiothoracic surgeons. And this is how it looked like. These were all septa. We broke all the septa, cleaned up, and we prevented the patient from developing a loculated collections or empyema. This was the histopathology, which turned out to be tuberculosis positive. Case 2, please.
So she was a 55-year-old female, a tobacco chewer, and known case of hypertension, and she came with complaints of breathlessness on exertion and cough. She also had loss of weight and loss of appetite, and she
fast, come on.
her examination revealed 94 saturation and there was decreased entry on the left side. And an X-ray chest showed left CP angle blunting. She was taken up for USG guided tapping, but it was a dry tap, so a CT scan was done which showed
a very minimal pleural fluid on the CT scan, if you can see, and it was all organized. So we took the patient for thoracoscopy. Sorry, yeah. We took the patient for the thoracoscopy. Unfortunately, we did not get a place, so we kept the, the trocar inside and allowed the air to go. We also insufflated some sterile saline to keep the lung collapsed. Once we went, and this is all malignancy. This is all malignant stradation of the visceral pleura. And if you look at the parietal pleura, look at all this thing is like a leather thick. This is classical of malignancy. What we did was we tried to pass in the forceps to take a biopsy, but it used to slip because of the thickness and the leather-like consistency of the parietal pleura. Hence, we introduced the cryo probe, kept it for some time and took the cryo biopsies. We took the cryo biopsies from here, and this was representative of adenocarcinoma of the lung. Since we knew that this is malignancy, we did the pleurodesis at the same time. So through, that's the reason, that's the beauty of the this machine. You can do everything. We insufflated the talc, so there is no recurrence of the filling of the pleural fluid. Ladies and gentlemen, this is my last case, and I would just take 2 minutes extra. We also enter into the domain of the critical care. And this is the airway bleeding, which is going to blow away your mind when we remove endobronchial blood clots from the patient who has got a complete collapse of the lung because of the bleeding, especially into the COVID pandemic when the patients are on an ECMO. Abhinav.
So 28-year-old female, COVID-19 ARDS on ECMO, and she was not generating adequate volumes on her ventilator, and the X-ray showed complete opaque lung, bilateral lung fields.
So this was the X-ray bilateral extensive white lungs. On the ventilator, she was not generating a tidal volume, nor was she generating the minute ventilation at all. I'll just show you, run through this. This is when I enter with the bronchoscope, a big, huge blood clot, which is not allowing the patient to be ventilated. I introduced the cryo probe. First, I have not activated it. I was trying to remove the clot from the wall, which is attached because of the dry blast of the ventilator. I have just separated this, and then I have gone inside again, and then we activated, and there was a formation of the snow plume over there. The blood clot got attached to the cryo probe, and the whole blood clot came out en toto. If you can see the blood clot coming out completely. This is the whole blood clot which is coming out. Look at the size of the blood clot which has come from the lung. Again we went inside, again the residual was activated, and we removed the whole of the blood clot from the right main bronchus. This is how the whole thing came out. And after that a repeat bronchoscopy showed the opening and the recanalization of all the airways. This is how the blood clots we had removed, and these are the times one of the blood clot took the size of the bronchial tube as well. Post this, the patient started generating tidal volumes and was maintaining a good minute ventilation, and we could achieve a good, and the patient of course survived later on post ECMO as well. So ladies and gentlemen, this is the place where we work, Abhinav and I, where we evaluate the patient, look the patients over here, which is Dalal Sleep and Chest Center, Kalyan Hospital, and this is the place which is our Karma Bhumi, where we do a surgery, or we do all the, and of course, maintaining the decorum of the cardiothoracic surgeon, but this is all we do. Thank you very much for your patient listening, and I would be honored to take all your questions.
Any questions from the audience? Yes, sir. Yeah.
Good morning. Madam, my question is for the pediatric group of patients. Your long-term of experience for the less than 6 years of age of pediatric patients who has swallowed or by mistake or by mischief, particularly in a fragile foreign bodies. So what is your experience, and how do you bring it out?
So unfortunately,
fragile items, fragile foreign bodies.
So unfortunately, sir, we don't practice pediatric interventional pulmonology. But yes, there are a group of pulmonologists who are doing pediatric interventions. So the only thing is...
So because of this, madam...
Sure. So there are rigid
diameter
bronchoscopes.
is less, it has gone to the distal bronchioles and other places.
It can be removed,
and
sir.
the foreign body is fragile also. Means it's difficult to particularly catch it, bring it out. And whatever the bleeding because of the fragile and sharp, like say pins, some electrical items like say uski bhi jo pin वगैरह होती है.
It can be done with a rigid scope, rigid bronchoscope, pediatric rigid bronchoscopes, and there are different handling forceps for that. So if you're talking about fragile, there are people who have ingested pins, there are people who have ingested even a safety pin, and it's open inside, right? So what they do, there are certain forceps. Through the rigid bronchoscope, they introduce those forceps, which has got a plunge. What they do is they'll close the safety pin inside itself, right? And then they take the whole thing out and toto through a rigid bronchoscope. The flexible bronchoscopes are not going to work in pediatric patients. They'll need a general anesthesia, rigid intubation, working with the rigid channels.
But with the same thing, like say pin is a different item.
I'm sorry?
Pin, if you give example of the pin, so it is catchable.
Of course it is catchable.
But
there are so many forceps.
When
Yes.
the thing, the foreign body is fragile, like when it catch it, it is broken into the particles. It is again when you catch it, it is broken into multiple particles. So that becomes a challenge for you people.
I understand, sir, but then there are pediatric interventional pulmonologists who are doing it and removing it.
Thank you. A pulmonologist would be happiest if we increase our total lung capacity by standing up and appreciate her talk. Let's stand up and give a big round of applause to Madam and her co-presenter. Now I welcome you down the stage for the felicitation. I request Dr. Rahul Parmar to present the memento to Sonia Madam. I also welcome chairpersons down the stage for felicitation. I request Dr. R.S. Patidar, Dr. L.H. Saini and Dr. Nitin Shah to present the memento to our chairpersons. To chair the next session, I welcome Dr. Deepak Kumar Mehta and Dr. Nitin Shah on the stage. Dr. Deepak Kumar Mehta is a senior radiologist and Dr. Nitin Shah is a practicing family physician. Now I welcome Dr. Nimesh Patel sir on the stage for his talk on scope of endoscope in brain and spine surgery. And I request the chairperson to introduce Dr. Nimesh Patel sir.
Good morning, everybody. Dr. Nitin Shah sir will introduce Dr. Nimesh Patel.
Hello. Good morning. I welcome Dr. Nimesh Patel. Dr. Nimesh Patel is MS DNB Neurosurgery, Neurosurgeon at Bailal Amin Hospital. Dr. Nimesh Patel has special interest in vast experience in performing endoscopic surgery, skull-based neurosurgery, minimal invasive spine therapy. He is pioneer neurosurgeon to perform cranial, ventriculoscopic and endoscopic and stereoscopic surgery in Vadodara. He is active academic member of Neurological Society of India, Skull-Based Surgery Society of India, Neurospinal Surgeons Association of India, Neuroendoscopic Society India, AOSpine. Over to Dr. Nimesh Patel.
Good morning, everyone. Thank you, Gimacon, for giving me this opportunity. I must congratulate to team IMA Vadodara for an excellent show. Now, what was considered as one of the morbid and high mortality branch once has completely changed in last 3 decades, particularly because more and more emphasis has been given in neurosurgery, not only to treat and tackle the pathology, but to minimize the brain damage. Henceforth, invention of new tools have literally changed the outcome of neurosurgery in past few decades. Endoscope is one of them, along with the microscope. So in last 2 decades, our main interest was mainly to reduce brain damage or brain retraction whenever we do any brain surgery. These are some pioneer people who has changed the literal meaning of outcome in neurosurgery. Most of you as a non-neurosurgeon person would know that endoscope or transnasal endoscope is commonly used for the pituitary tumor surgery. So my purpose of this talk is mainly to tell you that things have gone much beyond in the branch of neurosurgery. So we use endoscope in transnasal surgeries. Along with the pituitary tumor, there are so many other lesions also. Intraventricular and cranial ventriculoscopic surgery. I'm happy to share that we are the one who has started this in 2015 in the city of Baroda. I extensively use endo-assisted microsurgery for lateral skull base for acoustic schwannomas. And a new kid on a block in neurosurgery is called as endoport surgery for the parenchymal tumors. The major advantage of using endoscopic surgery or any minimal invasive surgery is not to sell the idea that you are avoiding craniotomy. You have to be very honest when you are acquiring any new tools. So purpose of any new minimal invasive technique is mainly, it's more about physics and principle rather than the size actually. And of course, along with that comes the safer post-op recovery and lesser hospital stay. So endoscopic transnasal transfemoral surgery, we all know, and probably most of you also know, that most of the pituitary tumors been operated in that way. This is one of the patient which I operated almost 10 years back, a large pituitary which was involving the cavernous sinus. Now these all surgery we regularly do transnasally, so I won't go into much detail. These are my tools for the transnasal endoscopic surgery. And can I fast forward this? It used to come actually. It's not coming here. Sure? Ideally it should be coming. The bar used to come here. It normally comes actually. Sure? I don't know. I'm sorry, but obviously I can't show the entire video. Please forgive me for that thing. And this is a little longer video, so constraining the time, it's very difficult to complete the entire topic. This is a transnasal surgery which we regularly operate through nose. I won't go in detail of the video because I won't be able to do a fast forwarding. This is the post-op result of the same patient, complete excision of the lesion, and he's doing absolutely fine. Can we do the larger lesions? Yes, this is the largest which I have done through transnasal route, but can we do even more? Of course not. So whenever you do a new tool and whenever you do such surgeries, you have to know the limitations also. This is the only case which I have done transnasally and transcranially both. And the reason behind that is that this particular lesion you can't reach through the nose. So first we did a transcranial surgery to remove that part and then the transnasal. So that's a post-op picture. He's doing pretty fine. These are our personal experience till now. In last 10 years, 103 cases, and most of the cases are doing fine. So can we extend the use of transnasal surgery? And that is what we have started in last 7 years. So not only pituitary, but I am doing regular surgeries for the anterior skull base area, for the clinoidal area, for the clivus area. This is one of the case which we operated 7 years back. Probably somebody first time has attempted in Gujarat to use a extended transnasal surgery. So this is a tuberculum cell meningioma, and we have removed it through the nose, not transcranially. The challenge was sella was normal, so we have to literally drill this area and then to reach to that particular portion. Now again, unfortunately, yeah, so happy. So this is the transnasal component. I'll just fast forward it and I'll just show you what we do actually. So that's the drilling through the nose, and that's the tuberculum cellae which we are drilling. These are all fine tools. On either side you have a carotid artery and the cavernous sinus. So it's a pretty precious zone. Once you drill that area, you will be able to see the dura. You do the micro dissection, expand that, and open the dura. Removing the tumor, we use a specialized equipment called CUSA to prevent the important structure damage. That's further tumor removal, as you can make out, further dissection, and this is all through nose. So this is the first time it was attempted transnasally here in Gujarat, and this is what we regularly do now. A further excision of tumor, you will be able to see the optic chiasm and third ventricle. So as you can make out, that's optic chiasm, that's third ventricle, that's CSF. Patient is doing absolutely fine. We have done quite a few cases of NTS cranial fossa base through nose. There is a CSF rhinorrhea. Nobody does craniotomy nowadays for the CSF rhinorrhea. We check CT cystoscopy and find out the leak where exactly it is, and that's the dura, the leak. That's further dissection, and we use, we use facial atta and fat to seal that thing. So this is all transnasally. I extensively use endoscope. Recently we have changed to 4K system, so you'll see the excellent book pictures actually. Hemifacial spasm and trigeminal neuralgia surgery is one of my favorite surgery. What we generally do is basically, now this is recently done case, as you can make out, that's brainstem. This is the picture of same patient, that's the brainstem, that's 7th and 8th nerve complex, and that's vertebral artery. So the vertebral artery was causing compression. As you all know, most of the physicians know what is the reason of trigeminal neuralgia. Same reason is there for the hemifacial spasm also. This is the same patient, exact picture, brainstem, facial nerve, trigeminal nerve, lower canal, and the vertebral. So our purpose is to detach vertebral, and we have to put Teflon here, which will prevent the irritation of root entry zone. And that's exactly what we did. This is the endoscopic view, first Teflon, then a second Teflon. So the Teflon has been put between vertebral artery and brainstem and facial nerve. And that's the endoscopic final picture. His 10-year-old symptom of hemifacial spasm is gone next day itself. So it's a beautiful tool. The purpose of using endoscope and minimal invasiveness is to prevent any particular normal brain damage. So the outcome has significantly changed. I regularly use the endoscopic assisted microsurgery for my acoustic schwannoma surgery, which are considered as one of the most complex cases, and epidermoid angle tumors. This is one interesting case, probably reported for the first time, a large epidermoid tumor. Now the challenge here, it is the dominant side of the brain. You all know that the left side is predominantly dominant for the speech area. I cannot reach microscopically here. So, and if you try to use microscope, you can damage the major structure of the brain. So purpose is not just to take out the pathology, but to go for the safe surgery also. And that's the endoscopic picture. So I'm using, my assistant is using the, holding the endoscope, and I am doing the dissection. Sorry, I have to kind of forward it here because I can't see this bar in my laptop. So I'm doing all endoscopic dissection here, and the tumor is been separated from the Broca's area and the sylvian fissure, and slowly you take out the lesion. So that's the final picture. You can make out a normal brain, the entire tumor is out, and patient is completely normal, no speech related issue. So the question is, if you can use endoscope from nose and from the lateral skull base and everything, why can't you use it from the brain? As you all know, laparoscopic surgery and urological surgeries has been advanced to this level. And this is where I have started cranial ventriculoscopic surgery in Baroda, 2015. Nowadays, for last almost 7 years, we don't do VP shunts in the obstructive hydrocephalus. The first and foremost indication for cranial ventriculoscopic system, this is a STORE system, is to do endoscopic third ventriculostomy. So as you know, the VP shunt is basically diverting the excess CSF from the cranial cavity into the peritoneal cavity. Here, we do it internal shunting, so you don't have to put any foreign material. I regularly operate and you can do intraventricular surgery through endoscope and lot many other indications. So these are the tools which we regularly use. So purpose of endoscopic third ventriculostomy is basically you enter into the lateral ventricle, through the foramen of Monro you enter into the third ventricle, and then you create a separate opening. So from third ventricle, the intraventricular CSF will go into the subarachnoid space from where it gets absorbed. So this is our first case. And as you can make out, now we are looking into the ventricle. So that's the choroid plexus. I'll just brush up your MBBS memory. And as that's the foramen of Monro, it's large. This patient was twice shunted at Kashiba, and I got a call, can we do anything, because the shunt got blocked. The major issue with the pediatric patient is shunt blockage, and that's why this particular procedure has come in picture. In adults, still the things are fine, but pediatric, you have a, you have a major issue with the shunt blockage. So now I'm in the third ventricle. What you are seeing here is the mammillary body, and that pink thing is the pituitary stalk. The previous pictures what I showed was transnasal surgery. This is intraventricular. You are looking at the pituitary stalk from inside. So we create opening here. From third ventricle, the CSF will directly go into the subarachnoid space. And that's the beauty of this procedure. We have done 43 cases till now. We are using this Fogarty catheter and expanding the area, and so nowadays we don't do obstructive hydrocephalus by VP shunt, we do endoscopic third ventriculostomy. Can we do tumor through the same endoscope? Yes, we can. So all intraventricular tumor we are now doing endoscopically, no craniotomy, nothing has been done for that. This is one of the cases which I did 6 years back. It's a colloid tumor at the foramen of Monro causing the obstructive hydrocephalus, young male. That's our position, the assembly, my assistants, and again the same. We are into the ventricle now. And I'll quickly go. So I'm sorry for the technical glitch. It's not working. Okay, so this is the foramen of Monro. This is the important, this is the interseptal area, and we are removing the tumor endoscopically. Once you remove that, you will be entering into the third ventricle. So all this is done. I'm not going in detail because I believe there is a little technical issue here. So that's the endoscopic kind of instrument we use. It's all STORE system, and that is all through a small incision. If you don't have endoscope, you basically do a transcranial route. That's the post-op picture. We have till now 24 colloid tumor surgery through endoscopy. same way we can use for the other cysts, like this is a porencephalic cyst, young lady came with the monoparesis and the lesion was exactly into the motor area. So if you don't have endoscope, you use transcranially. The purpose here is to connect both the cavity and then connect this to the ventricle. It's a normal fluid, it's not a tumor, you don't have to kind of remove it. So this is the same patient video. I have entered into the cavity and sorry, I think there is a little technical issue, so I won't go in detail of that. This is another case with a large arachnoid cyst, all done endoscopically. We have connected this particular cyst into the basal cistern. As you can make out, so that's the tentorium, that's the neurovascular structure, and this is all through endoscope. These are my instruments. So I am connecting that large cavity of arachnoid into the basal cistern through the endoscopic route. So no craniotomy, nothing is done. Very interesting case. We have 12 such cases till now and we are in the process of publishing. A 3-month-old child, call came by a pediatric neurophysician to me that a patient has a severe ventriculitis with a high cell count in the CSF and nothing is working. Can you do something? And this is our first case. So if if we couldn't do anything, probably this child would have died. So this is almost 5 years back, a large infected cavity in connection with the ventricle and no antibiotic was working. The patient was referred from Kashiba to Bailal, and what we did was something which I did for the first time. Technically it's simple, but conceptually it was little difficult. So this is a large cavity. Now it's all infected and that's the 3-month-old child. This is my own position because we could not put any particular frame for this head. And that's the video. The moment I enter into the cavity, it's all yellow. It's all infected. So what I did is basically, it's like debridement and giving more wash. The same thing we use ringal lactate and antibiotic fluid to give a wash, connected all the cavity and made it a single thing. This is the opposite side ventricle which was still better. So, and that's where I am connecting all the septas and using the scissors to make it a single cavity. Now here, as I mentioned, all the toys have its limitation. This case was not to substitute this patient for the shunt, no. This is to buy a time from that critical condition so that at least we can save this child and we can do further. We have to do VP shunt in this case because arachnoid, the subarachnoid space was anyway bad. We cannot convert the intraventricular into the subarachnoid because there was no subarachnoid space. Child survived and we did VP shunt after a month and the child is doing absolutely fine. If this would not have been done at that time, probably he would have died. So we have such 12 cases and we are in the process of publishing that. I am not going into detail of the spine surgery. Minimal invasive spine is one of my major domain and many other people are also doing. What we do is microscopic and endoscopic. This is my Medtronic set. I won't go into a whole lot of a different topic, so I am not going in detail of that. This is one of a case where severe spinal canal stenosis is there. That's my tool. I either use endoscope or microscope, and that all you can do a drilling and everything through the same MIS tube. That's the picture. Nowadays, even the fixation we do minimal invasively, so you don't have to literally open in the center whenever it permits. Obviously, cost is still an issue in this kind of era, but we are evolving. So, take-home message, minimal invasiveness component has to be used aggressively in brain surgery, mainly for the better outcome. I'm happy that I'm an active member of Neuroendoscopic Society of India and had an honor to present Gujarat as a faculty in recently organized International Federation of Neuroendoscopy meet. Thank you very much.
Any questions?
Sir, you said about Teflon application
yes.
in terminal neuralgia. How does it remain in situ for longer period?
Yeah, it remains actually the Teflon material that's where the technical skill come, how you put the Teflon actually. Nowadays we use glue also to keep it there actually. People have tried taking stitches and everything to the dura and then keep it there, but it never works actually. But by and large, if you put it nicely, it stays at that level. It's a sticky thing actually. But yeah, still, 95% of the success rate is there in all this surgery. The 5% failure is related to the Teflon migration. But that's the reason why we use glue also now for the Teflon. Our intention is mainly, rather than putting Teflon, if possible, to take away that loop and put over the dura and then stick it with the glue. But all the time it is not possible. Like this was a typical anomalous vertebral artery, so you can't literally mobilize that artery. But it stays, it's not a major issue.
What's the cost, sir?
Sorry?
Cost?
I don't know, it's not that costly.
I'm a pediatric surgeon.
I know, sir, you.
Thank you. Since about 3 decades, still we are doing that conventional VP shunt in congenital hydrocephalus. So what is your comment?
Sir, things have significantly changed in the branch of pediatric neurosurgery. I am by far a fellow of pediatric neurosurgery also. I'm basically born and brought up in Baroda and did everything from Baroda, but I'm trained in Kerala actually, and we had a separate pediatric neurosurgery department. We used to do neonatal neurosurgery in Cochin, yeah. The biggest issue with the pediatric neurosurgery is to have NICU and PICU at the same place. The biggest challenge what I am facing in Baroda, the youngest child which I did was 3-month-old. I have done pediatric tumors also, but the biggest challenge is if somebody is less than 5 years, still above 5 years we can manage at Bailal, but less than 5 it's next to impossible and we cannot take that. So even now with that 3-month-old child which I showed you, the patient actually was shifted from Kashiba in the morning. I did the procedure. We informed, this was Sabani's case actually. So we organize, even now also we do that thing. The ambulance from a so-and-so pediatric ICU will be standing there and we'll be coordinating everything and we'll shift back. So that's the biggest challenge in developing pediatric neurosurgery actually. I hope a day will come, most of the corporate feels it's not cost effective. But I think if we really need a good result, we have to see beyond cost effectiveness. So, but if you ask me, endoscopic third ventriculostomy is definitely the gold standard for any obstructive pediatric hydrocephalus. It will, you know, you are a pediatric surgeon, how many times we see a patient with shunt infection and shunt block. And believe me, it is one of the worst case scenario to manage a shunt infection. We all know that thing. It's pathetic, the parents and child. If you can literally avoid doing it, here we don't put any foreign material. And it's wonderful. The first ETB case which I showed was actually twice VP shunted in Kashiba only. And third time when the blockage came, and that was my first ETB here and this is almost now 7 years. She regularly comes for the follow-up. We have removed the old shunt. She's absolutely fine. So I think it has to be promoted more. The challenge is having PICU and NICU and a neurosurgeon at the same place. That's the problem. These all are little tool-oriented surgery, toy-oriented surgery. So there is a limitation. If you ask me to come and do surgery, it's next to impossible because I need my setup. It's in that way. So let's hope we are progressing. This was also not done here. We are doing it now. And cranial endoscopy, I'll be happy to tell you that we are the only one who are doing in Baroda. We started in 2015 actually. Thank you.
So due to paucity of time, we will take next questions into the lunch session. Our faculty is with us only. So thank you, sir. Now let us do a no cost intervention. Please stand and clap for the excellent talk. Thank you, sir, for the awesome talk. Now I welcome you down the stage for the felicitation, for which I request Dr. Nitin Shah to present the memento to sir.
Excellent talk on endoscopic brain and spine surgery. Now, by the time the felicitation is done by Dr. Nitin sir, of Dr. Nimesh Chavan.
Now I welcome Dr. Prashant Buch sir on the stage for his talk on when, where, and whom to refer critical patients with liver disease. Friends, believe me, this is a harsh reality of nowadays. If you don't know it, then patient's relatives, friends, well-wishers, or just dial or Google will do. When to refer, whom to refer. So have a complete focus on this talk to avoid all these modes of referrals. I request the chairperson to introduce Dr. Prashant Buch sir.
Dr. Prashant Buch sir is a senior, one of the senior most gastroenterologists. He is MD and DM in gastroenterology working at the Bilal Amin Hospital. And I think that whole of the Baroda knows he is one of the very senior and very sincere gastroenterologist. His special area of interest is liver disorders besides GIT. And he is going to talk about where, when and whom to research the critically patients with the liver disease. Because liver disease nowadays is taking a toll with the changes in the lifestyle and sedentary life. So over to Dr. Prashant Buch sir.
Thank you. You know, the reality of life is that doctors get beaten up by relatives. Now, of all the doctors who have been beaten up, the gastroenterologists have never been beaten up, even though we deal with all alcoholic patients who are quite violent. But that's because we know when to refer. So that's exactly what I'm going to share. Unfortunately, my talk is not very complicated. I'm going to talk those things which have been there for the last 50 years.
Sir, please be close to the mic. Please be close. We are not able to hear you.
So I'm going to talk something very basic, something what we can remember and practice in our day-to-day life. Now, basically, I'm going to focus on when a patient comes to you in your clinic, how do you make out whether this patient is very ill and needs a referral? You know, if the patient is vomiting blood, the patient is unconscious, deep yellow eyes, tense ascites, you know, and you always send him. The problem is when the patient walks into your clinic and says, doctor, problem che, and then you have to know that, oh, this man is serious, this man is not. Let's try and figure out how can we do that. We'll do that from history, clinical examination a little bit, and from some basic instruments, nothing very sophisticated. So I'm going to just focus on an acute hepatitis and cirrhosis. Now, acute hepatitis, the commonest causes what we will see would be viral hepatitis, alcohol, and sometimes drugs. Anti-TB therapy is the commonest cause of drug-induced hepatitis. It is necessary to know which patient is having a severe disease because a severe disease requires ICU care. A severe disease may require a liver transplant. Whereas the mild acute hepatitis, I mean, there is no medicine. You just have to keep him comfortable, feed him well. He can be managed at home, does not even need hospitalization. Now, the clues for severe liver disease, which you can pick up in your busy OPD are, if the patient of viral hepatitis continues to run fever after the onset of jaundice. સાહેબ તાવ આવ્યો પહેલાં બાજુમાં ડૉક્ટરે કીધું કે ટાઇફોઇડ છે દવા આપી મટ્યો નહીં 5 દિવસ પછી આંખો પીળી થઈ ગઈ. So you have done the blood test and you found that it's viral hepatitis A. That's good, that's common. But the patient comes back out of 5 days કે સાહેબ દવા આપી પણ હજી તાવ ચાલુ છે. Now that is where you have to be careful. Because continued fever means that hepatic necrosis is going on. So that patient requires some more time to be spent. If the patient suddenly comes developing a big abdomen, I mean if it's a woman you suspect pregnancy, but in a male you suspect ascites. If the patient is elderly, by elderly by definition is somebody who is more than 60 or 70 years of age, and if that patient develops jaundice, it is likely that this patient could have a bad course. So that patient needs more attention. I'm not saying that they all are critical, but these are the people whom you need to spend more time. If the patient is immune suppressed, patient is on steroids for asthma, patient is on rituximab for rheumatoid arthritis, the patient is suffering from some hematological disease and the hematologists are thumping the patient with a whole lot of drugs, and if that patient develops jaundice, don't take it lightly, that jaundice requires intense investigations. Also remember, just because the patient has high bilirubin does not mean it's a severe disease. Just because the patient has itching does not mean it's a severe disease. And if the SGOT, SGPT are high, it helps you make a diagnosis. It does not tell you about the severe disease. So if the patient comes to you on day 1 with anorexia, nausea, vomiting, you do not do any investigations and you do investigations on day 5, the SGOT, SGPT will be 2000. But if you did investigations on the first day, the SGOT, SGPT would be 10,000, 15,000. No, that doesn't mean it's a severe disease. It only means that your diagnosis is correct. What is important, which you need to do in the practice, is measure the prothrombin time. Now the first prothrombin time is most important. So please get the test done in a very, very reliable laboratory. Please do not try and collect the blood yourself. Keep it on your desk, and when the technician comes for his usual rounds, give him the sample. No. This blood has to be collected by a qualified technician in a very proper manner. Otherwise, the reports are going to be wrong. Prothrombin time is important because any value which is more than 2 times the upper limit suggests a severe liver disease. It will mean hospitalization and close observation. This is, I stress again, if the prothrombin time is more than twice the upper limit of normal, that patient has to be referred, that patient needs a workup. Please also remember, high prothrombin time does not mean the patient has a liver failure. So don't tell him that tamaru liver fail thai gyu chhe. Just tell him that you may have a serious disease. This may deteriorate, hence a close follow-up is required. The other thing is, just because the prothrombin time is high does not mean that the patient is going to start bleeding. This is just a sign of a severe liver disease and other complications may occur. Now, that is for viral hepatitis. Let's go down to a more interesting disease, alcoholic liver disease. An alcoholic liver disease, the patient may present with fatty liver, the patient may present with alcoholic hepatitis, which can be severe, the patient may present with cirrhosis of liver. You all have seen these patients, you all know how to make a diagnosis. A fatty liver patient is going to live longer than you. A patient of cirrhosis will live reasonably long if he stops drinking alcohol. There is no emergency, no critical need to refer at this point of time. Problem is with alcoholic hepatitis. Now, if the patient has severe alcoholic hepatitis, the patient says, he's drinking alcohol. The wife says, અઠવાડિયા સુધી દારૂ ખૂબ પીધું હતું અને હવે આંખો પીળી થઈ ગઈ છે, ઉલટીઓ થાય છે, and the patient is still walking, slight pedal edema, and reports show it's a severe alcoholic hepatitis. How? I'll just tell you. 70% patients will die in 2 months. So severe alcoholic hepatitis is probably more dangerous than a coronary artery disease, which of course can kill immediately, I agree. It's more dangerous than any malignancy. And these patients die very fast. So how do you make a diagnosis of severe alcoholic hepatitis? That's all you have to do. When a patient of alcoholic liver disease comes to you, is it a severe disease, severe alcoholic hepatitis or not? That's it. So the method is very simple, it's there on the internet, but basically it's a simple score. Bilirubin with a multiplication of elevation of prothrombin time. Let's take an example. A patient has come with a bilirubin of 8. He has walked into your clinic. The prothrombin time is 19 seconds, not too prolonged. But 8 with elevation makes a value of 52. This means that even though the patient is fully conscious, stable, walking, arguing with you, arguing with his wife, he still has a severe disease. Any value more than 32 is a sign that the patient requires admission, intensive therapy, and this is the patient who might require a liver transplant. So you can imagine, I am talking not of a patient who is there on a stretcher brought to your clinic. I am talking to a patient who has walked in or driven in his own scooter to your clinic. But if the bilirubin and prothrombin time are high, he needs admission. Patients who have a value less than 32 can always be managed at home. They don't require any special therapy. The commonest mistake made in referrals to a gastroenterologist are that when a patient who looks otherwise stable but has a high DF value or values more than 32 are not referred. And then when the patient comes in a more severe state, it's unlikely that they will survive. This is one of the most controversial aspects of hepatology. How do you manage severe alcoholic hepatitis? The important thing is it's controversial because treatment has a different, results, endpoints are different, results are different, but we need to refer these cases first. These are the cases best managed in tertiary care centers. Now, that was hepatitis. So let's look at cirrhosis of liver. We know how cirrhosis presents. Eyes maybe not yellow, pedal edema, some ascites. Basically, there are two stages of cirrhosis. Either it's a compensated disease or it's a decompensated disease. If the patient has a compensated disease, he'll live long. You have enough time to play around with him. But if the patient is decompensated, the patient is in trouble and we need to do something very fast. How do you make a diagnosis of decompensation? No fancy instruments required. Just see, does the patient have ascites? Yes. If the patient has ascites, it means he has decompensated. It means he has a limited life. Please try and understand. The onset of ascites is not the beginning of the disease. The onset of ascites is the end of the patient. Hence, the ascites can never be taken lightly. Yes, the ascites will respond very well to aldactone and Lasix, but the fact that ascites has occurred, you need to refer. Don't ever take patients lightly. I will go to the extent of saying that when a patient comes to you with a liver disease and he has ascites, and the patient says, Sahib, ketlu jivis, you are not justified in talking about liver transplantation at this stage. So that itself suggests the seriousness of the condition. If you have ascites, please don't ignore it. Now, besides ascites, a patient of cirrhosis may come to you with some abnormal liver function tests, kidney functions reasonably normal. But the problem is, how do you make a diagnosis of kidney failure in a patient of cirrhosis? See, a patient is in the ICU, the intensivists have multiple ways of checking this thing out. I am talking about a patient who is walking into your clinic with some reports, and you have to give an answer. We all know that if the creatinine is high, it means that the patient has kidney failure. Creatinine is dependent upon the muscle mass. And cirrhotic patients have a low muscle mass. So cirrhotic patients, normal creatinine is on the lower side. So normal being 1.2, a cirrhotic would have a normal creatinine of 0.6, 0.7. So any creatinine which is closer to 1.2 or even 1.3, it is a sign of gross renal failure. Gross renal failure, not a mild renal failure. So any patient with even a marginal elevation of high creatinine, the alarm should start ringing. That patient needs a referral. He may not need dialysis. Generally, they don't need dialysis. He needs a referral. You have a patient with a creatinine of 0.7 in your OPD. He has come to you for some minor viral infection. After 3 days, you get his blood test done again and his creatinine has gone up from 0.6 to 0.9. It is still less than 1.2. But even if the creatinine goes up by 0.3 over 2 to 3 days, it means that the kidneys are deteriorating. The urine output may or may not be less. The patient may not measure his urine output. You may not ask about urine output. But if the creatinine is slightly going up, refer the patient. Please remember, a patient of ascites with high creatinine does not live longer than 6 months, unless or until you can bring the creatinine down. A patient with ascites whose creatinine keeps going up, keeps requiring repeated admissions and specific therapy, this is a hard indication for a liver transplant. If a patient goes for a liver transplant with a high creatinine, the mortality is high. So if the creatinine starts rising, get his liver changed faster than you can think of. So, I keep talking about liver transplant. So we are talking of something which costs anywhere between 15 to 25 lakh rupees. So can our patients afford it? I didn't think so. I thought कि कौनी पास है 25 लाख रुपया छे. But then you look at it, look at all the car park, all the cars standing there. 50% of the cars will be costing more than 20 lakh rupees here. 25 lakhs is not a big sum for a patient to save his life. When you especially are going a therapy which is altering the natural history, it's not just like, some minor palliative procedure. So please talk about liver transplants to the patient in a more positive manner and let the patients take a decision whether they want to undergo or not. Now, this was all very serious disease. All of us sitting here, a large proportion of us have a liver disease. All of us have it. I mean, you'll be surprised at how many do not have a liver disease. So, which is the commonest liver disease which all of us here are having? I am having, you guys are having. So, the patient is an overweight patient. He may have diabetes, he may have hypertension, he may or may not be drinking alcohol. His liver functions are reasonably normal, but a sonography showed that he has a fatty liver. So the patient comes to you saying, "Sahib, fatty liver છે શું કરવાનું?" Okay, you say વજન ઘટાડો. હા ઠીક, બીજું શું? કે ડાયાબિટીસ કંટ્રોલમાં લાવો. એ તો થશે, બીજું શું? લિવરને લીધે હું મરી જઈશ? Simple question. So the answer is થઈ પણ શકે કે બધા લિવરના ટેસ્ટ તો નોર્મલ છે. So I mean, how do you decide whether that man has a serious liver disease or not? So fatty liver gives rise to inflammation, and the inflammation gives rise to some hardening of the liver or fibrosis. This is not cirrhosis, this is just fibrosis. So only those patients who have got advanced fibrosis will develop a significant liver disease. The commonest cause of death in patients who have a fatty liver is a coronary artery disease, not a liver disease. The commonest cause of death in patients of fatty liver disease who have advanced fibrosis is cirrhosis. So the goal is to pick up advanced fibrosis. So in past, it was done by doctor paase jao, liver biopsy karao, painful. Nobody likes a big needle poked into the liver and then you have to pay for it also. So nobody likes that. So what is the modern way? The modern way is, can we pick up fibrosis in a non-invasive manner? And the answer is fibroscan. Now, I have been giving this lecture many times and I have consistently shown this particular photograph, and a common mistake has been made. Everybody, all males, get very excited when this photograph is taken. So let me clarify. Fibroscan is this machine, not the lady standing there. Okay, this was from an ad. So this is the machine which we are going to use for doing fibroscan. Your technician may be a bearded guy or anyone. This was a French photograph. So what is fibroscan? So in fibroscan is like a sonography machine. So you take a probe, it's put against the liver. Now from the central part of the probe, some vibrations go, and the peripheral part of the probe picks up how well is the liver vibrating. And this tells us about how stiff the liver is. The stiffer the liver, more is a fibrosis. Example, you take a bowl of ice cream, you flick the ice cream. The ice cream will, move a little bit of ice cream, but it will remain as it is. You take jelly and you flick it, and the jelly shudders. So something like this. The jelly is stiffer than ice cream. So you get a value something like this. That is how the vibration, the wave goes. This is for checking the fatty liver. And you have a value something like this, a fibrosis score. On basis of this score, you can confidently say whether the patient has advanced fibrosis or the patient does not have advanced fibrosis. So with this one simple tool, you can clearly tell the patient whether he has advanced liver disease or not. This is not a toy for the gastroenterologist. Yeah, everybody thinks fibroscan to gastroenterologist vapre. No, the fibroscan is one toy which I should not be using it. All of you should be using it, because majority of your patients will not have advanced fibrosis, and a fibroscan will rule out advanced fibrosis even though they have a fatty liver, and you will have to then focus entirely on obesity, diabetes, hypertension, something what the gastroenterologists are terrible at doing, but you all can do it so much better. So the patient remains with you and the patient is reassured that he does not have a significant liver disease. But on the other hand, if the fibroscan shows a high value, don't waste time. That man needs more aggressive workup for everything, for his metabolic control. He may even need bariatric surgery. So to summarize, whatever I have said, a high INR or a high raised prothrombin time is an indication for immediate action. The mildest rise in creatinine is a sign of impending trouble, needs referral. A DF score in an alcoholic hepatitis of more than 32 means admission and therapy. Refer a patient to a liver unit when the INR is more than 2, when ascites develops, when the fibroscan shows a value of more than 8. Liver transplantation will control the problem, it will solve the problem, but liver transplantation is expensive, and believe me, with some very basic care, we can avoid referring a patient for liver transplant or even to a gastroenterologist. Thank you.
Thank you, sir. Dear friends, in our Gimacon 2022, we, the organizing committee, Dr. Neeraj Chawda, scientific chairman, and others have tried to bring all the stalwarts, leading experts of their field for updating you all. So let's stand up and give a big round of applause to one such stalwart of gastroenterology.
Any questions from the audience? If there is a question or two, we can take it, otherwise.
Due to paucity of time, we are not entertaining any questions. So thank you, sir. Thank you for your excellent talk. Now I welcome you down the stage for the felicitation. I request Dr. Deepak Mehta to present the memento to sir. Now I also welcome the chairpersons down the stage to the felicitation area, for which I invite Dr. Siddharth Nayak sir and Dr. Hitesh Vasawa to present memento to our chairpersons. To chair the next sessions, I invite Dr. Jagdish Patel sir, Dr. Uma Nayak madam and Dr. Kalpit Bakshi sir on the stage. Dr. Jagdish Patel is a trustee at Kasiba Children's Hospital. Dr. Uma Nayak is a very senior pediatrician, professor and head Department of Pediatrics at Parul University. And Dr. Kalpit Bakshi is a senior orthopedic surgeon practicing in Vadodara. Friends, you all will agree with me that every head has its own headache. So to deal with such kind of queries, I welcome Dr. Manan Mehta sir on the stage for his talk on approach to headache, and I request the chairperson to introduce Dr. Manan.
Hello.
Dr. Manan Mehta, MD, DM neurologist, currently working as a consultant neurologist at Mehta Neurology Center, Vadodara, Tricolor Hospital, Vadodara. He has 15 national and international publications, honorary post as neurologist, GMERS Medical College, Vadodara. His key interests are demyelinating disorders, headache, neuromuscular disorders, and neurocritical care. Dr. Manan Mehta, please proceed.
Thank you, sir. Very good afternoon to one and all, and thank you for giving me this opportunity to talk about one of my favorite topics, headache. So I was sitting in the audience and I was looking at the spectra of speakers as well as the topics, and I found that my topic was the least fascinating because probably the name is just approach to headache. But I think if there are 100 people listening to this topic of various specialties, all of them, maybe of any specialty, maybe dermatology, gynecology, everyone would have encountered a headache patient once in a while, at least once in a week or once in a month. So probably at the end of 20-25 minutes, I would be able to briefly give you a very simple approach, not what I know or what not. I don't want to spend on talking about neurology part, but basically how do you approach, not miss red flag signs and treat migraine a little bit better. In our country, we know that headache is the most neglected topics. What we are dealing with? We are dealing with poverty, illiteracy, TB, HIV, leprosy, coronary artery disease, boycott Bollywood, who will win the next election. But headache stands the last of the list. Every headache patient thinks he knows the diagnosis. He says, "ए तो मने वात पित्त gas acidity थी थयु." Headache, he says that "ए मने आँखना problem थी थयु." He says that "मने glaucoma छे, sinusitis छे." But is it true, or we need to do a little more? Treatment of headache is often delayed. There are a lot of patient-related barriers, lot of misconceptions that it is always because of आँखना number, chashma, visual acuity. It is always because of emotional upset, stress, decreased emotion, like excessive emotions. There is no permanent cure of headache, so I am not going to treat it. Headaches are usually caused by sinusitis, acidity, constipation. Because of that leads the headache disorders. Patients try to self-medicate before reaching to a proper doctor. Most of them have already taken some medication by their own. There is poor compliance. We know a lot of patients roam here and there with files of a lot of neurologists and physicians with no despair. No one is spared. One of the greatest female athletes, she suffered from menstrual migraine and had to withdraw from a tournament because of that. Yes, Serena Williams, one of the most dominating female athlete, had to withdraw because she suffered from menstrual migraine. Our Bollywood star, Shah Rukh Khan, he had migraine and he suffered a lot during his film. Even the great President John F. Kennedy, during his presidency days, he wrote an essay, how he dealt with migraine during his presidency. So this brings to more of a scientific discussion on how we classify headache as per the international guidelines. It is very simple. First is primary headache. Primary matlab the headache headache is a symptom as well as headache is the disease. And secondary meaning the headache is a symptom but disorder is something else. And lastly, in the third part, it is classified as painful cranial neuropathies, for example, commonly seen as trigeminal neuralgia. So three main categories. Number one is primary headache, which comprises of migraine, most common, tension type headache, trigeminal autonomic cephalgias, and other primary headache like primary stabbing headache, primary cough headache, ice picking headache, etc. For us, most important to remember is the first three: migraine, tension type headache, and trigeminal autonomic cephalgia. A secondary headache, meaning there is something wrong inside the body or the brain which is leading to the headache, and we need to investigate these kind of headaches. How do we categorize them? Number one, trauma to the neck and spine. A vascular disorder, maybe intracranial or extracranial, causing like dissection of arteries, subarachnoid hemorrhage, temporal arteritis, or AV malformation. A non-vascular intracranial disorders, something like space occupying lesion, a tumor, low CSF headache, for any reason raise ICP causing headache. Substance abuse or substance withdrawal. Many of our patients having knee issues, back issues, they have a tendency to take Ultracet or Tramadol because it is a non-renal involving drug. But after that, stopping those, patients have rebound headaches. Disorders of nose, sinus, teeth, ear, all are referred pain causing headache. Common drugs like nitrates are cardiac patients, sildenafil for pulmonary hypertension, aminophylline groups for asthma, OC pills for various uses. They cause headache. And lastly, psychiatric illnesses have an overlap with headache syndromes. So now I will brief you our 10-point approach, what we usually practice in our OPD setting, and this can be easily incorporated in your clinical practice on a daily basis. So this is a common picture that inside a doctor's mind, the doctor thinks, I will give him an aspirin or an naproxen and send him home. But the female thinks she has a tumor because someone in the family had a tumor in the past. History is the most important thing. We spend most of our 80% of our times in taking history while dealing with a patient of headache. We become Sherlock Holmes. We ask whether it is a first or worst headache. આ પહેલી વાર થયું છે કે પહેલા પણ થતું હતું પહેલા. So usually a primary headache like migraine or TTH, they start between 20 to 50 years of age. And in females during their menarche age, they start and last up to menopause. But a headache after the onset of 50 years of age, the new onset headache should be taken as a red flag and cannot be ignored. Also, a patient of having a routine headache, that doesn't mean that he does not have a secondary headache. In such scenarios, we ask whether this is a routine headache, whether there is any change of character, intensity, or the type or pattern of headache. Second question, what are the symptoms before, during, and after the headache? We all know that migraine patients will have photophobia, phonophobia, nausea, vomiting, and especially in patients of classical migraine, they have visual auras. Visual auras have floaters of flashes of lights, floaters of scotomas, scintillating lights, colorful lights. In patients of cluster headache, they will have a periorbital pain, watering from eye, ptosis, lacrimation, and rhinorrhea. But in secondary headaches, the patient will have symptoms of focal neurological deficits, may have rash, fever, disorientation, balance problem, or diplopia. So, associated symptoms along with headache are important. Third question is, how did the headache start? Most important is whether it is sudden or slowly, gradual. If it is a sudden and an acute onset, please do not ignore this headache. It is a red flag. Especially a patient coming to you late in the evening or patient landing up in emergency for headache, those patients, 9 out of 10 times, they cannot be primary headache, they are secondary headaches. Sudden and severe onset of headache can be due to subarachnoid hemorrhage, vascular malformation, intracerebral hemorrhage, CVT, dissection of artery. Primary headaches like migraine and TTH are gradual in onset and slow to peak. So another question important is, how is the peaking of the pain? So migraine usually starts slowly and there is at least 3 to 4 hours of time period when it peaks. But in secondary headache or headaches which need urgent attention, the headache peak onset is very important and it rapidly progresses. Fourth question is, what is the location and radiation of headache? The classical textbook definition of cluster headache is it is strictly unilateral. It cannot go on the opposite side. If the patient is saying that sometimes it is on the right, most of the times it is on the left, it cannot be a cluster headache. Cluster headache is strictly unilateral and periorbital. Tension type headache is usually dull aching, band-like in the frontotemporal region. Migraine, of course, typically if someone says that it is unilateral, but most of the times the common misconception is that it is always unilateral. No, it starts with unilaterally and then spreads over the entire head. Pain along the temporal artery may suggest temporal arteritis. Pain along the distribution of trigeminal nerve may suggest trigeminal neuralgia. These are all unilateral headaches. Pain around the eye with redness, don't forget our common diagnosis, acute glaucoma. Fifth point to ask your patient is, how is the severity and quality of pain? A tension type headache will be mild to moderate, pressing or tightening. The key point here is a tension type headache will never cause disability in your daily activities. It is a dull aching. Patient can do his daily activities. Patient is working on a computer, is an IT professional or any other work he can do with this headache. A cluster headache on the other hand is very severe, explosive, and it peaks within 1 hour and patient has to do a rest, and sometimes the patients cannot even rest. It is so bad that he has to move here and there. Migraine headache is crescendo pattern, moderate to severe, dull aching, pulsatile and throbbing. And other secondary headaches are moderate to severe, and these patients will definitely come to you because it is a secondary headache. Sixth point, ask the patient whether there is any postural variation or not. As in, if the patient typically complains that when he is lying down, he is absolutely fine, and as soon as he gets up or sits up, there is severe fronto-occipital headache, then suspect a low CSF pressure headache. This is very common post-spinal anesthesia, post-pregnancy, post-delivery by LSCS method. This is very common. And these patients usually they improve conservatively. Recumbent position and hydration is the most important treatment. SOS, they require an intrathecal blood patch. Last, seventh question. Identify red flag signs in a patient coming to you in OPD. These signs are, number one, headache beginning after 50 years of age, sudden onset of headache, headache with increasing in severity and frequency, a new onset headache with risk factors like malignancy or HIV, headache with systemic features like fever, neck rigidity, rash, headache with focal neurological signs like weakness of one side of the body, facial deviation, diplopia, headache with raised ICP, signs of papilloedema, headache followed by trauma. This is a good mnemonic where we can identify secondary headaches, where just the patient has headache and we have to look for these causes so that we know that it is not a primary headache and this should not be neglected, this should be investigated further. SNOOP, S is for systemic features like fever, weight loss, anorexia. N is for neoplasm history. N is for neurological deficit. O is for how onset, how fast, rapid, sudden. Another O is for elderly age. P is for pattern change. So many times it is common that a patient is suffering from migraine from long time, but there is a change in pattern and we have to look for another cause. P is for papilloedema on examination. Postpartum or during pregnancy should be investigated. Post-traumatic. So these are small things that we can keep in mind. 8th point, examination. We all know it's a very busy practice, headache are neglected, but at least 4 signs should not be, 4 symptoms should not be ignored on examination. Number 1 is consciousness, whether the patient is awake, alert, dull or drowsy. Eye signs, look for pupils, extraocular movements and fundus. Look for signs of meningeal irritation, neck rigidity, Kernicks. Plantar examination whether Babinski is positive or not. And lastly, most important, especially for physicians, blood pressure is important because many a times these patients comes with 200 by 100 BP and then we know this is the cause of headache. And what I want from my ophthalmology friends is we document vision acuity. IOP, glaucoma is very much underestimated as a cause of headache in patients, especially patients above 50 years of age. And SOS perimetry. 9th point, lab investigations are usually not required. Blood test is only required when we are suspecting a systemic or a meningeal infection. ESR is done to rule out a temporal arteritis. Neuroimaging, most of the patients coming to your OPD will not require a neuroimaging. However, in an acute setting, to rule out an intracranial bleed or a CVT, neuroimaging is required. I want to highlight here is that focus on a contrast neuroimaging, because most of the patients come to you with a headache and a normal MRI, but subtle signs of pachymeningitis or leptomeningitis may be missed if the contrast is not done. A lumbar puncture is warranted when we are suspecting infection, meningeal irritation, malignant meningitis, especially a occasion of CA lung, CA breast, who comes to you with a new onset of headache. And lastly, pressure monitoring. Lumbar puncture in patients of IIH, idiopathic intracranial hypertension, that is the only diagnostic method where you do a CSF opening pressure to diagnose IIH. And lastly, a treatment plan. So treatment plan should be, whenever a patient comes to you with a headache, always look for a secondary sign, look for a danger symptom, and whether this patient needs to be investigated or not. 90% of the patients coming to you with headache are of primary headache, and out of that 90% of them are migraine. Most of them are migraine, and proper etiology, appropriate treatment is decided only after proper etiology is established. Here I would like to speak about 5 to 7 slides on migraine, because this is maybe most of us, some of us have been suffering from this migraine attacks because of doctors having a busy lifestyle, erratic food habits, erratic sleep disorder. So I would like to brief you about migraine on this. Migraine, one of the most common causes of headache entire world. 33% of the females, that is 1 in 3 female, suffers from some form of migraine. Remember that more than 70% of the patients will have a genetic predisposition. If you ask whether someone in the family has migraine attacks, mother, father, siblings, 70% of the times you will get a positive reply, yes, they have. It is characterized by episodic or chronic depending on the frequency per month. The types of migraine are migraine without aura, that is the common migraine where you have unilateral to holocranial headache, throbbing as well as nausea, vomiting, but there is no aura. A classical migraine is migraine with aura, which is less common than the common migraine, but here we have diagnostic clues that patient will have visual aura, a brainstem aura like giddiness, vertigo, ataxia or diplopia, and hemiplegic migraine where the patient will have some sensory symptoms or motor weakness transiently for 3 to 5 minutes. Of course, these patients with aura have to be ruled out a space occupying lesion or a vascular event when they come to you. A chronic migraine, a long-term chronic migraine for more than 1 year and more than 3 months of headache. A status migrainous, that when the patient headache lasts for more than 72 hours and not relieved by any medication. And episodic migraine syndromes, especially seen in pediatric population, where abdominal migraine or cyclic in vomiting, these are episodic migraine syndromes. At least 5 attacks fulfilling the criteria where the headache lasts for 4 to 72 hours. It is unilateral in location, pulsatile quality, moderate to severe intensity, and aggravated by physical activity, relieved by rest. Associated with nausea and or vomiting, associated with photophobia and phonophobia. So because these criteria are established, because it's easier for you to diagnose and categorize the patient whether it is falling into a classical or a common migraine, whether it is severe form or a moderate form. In migraine with aura, the classical visual aura is the most common form of aura. Aura is described as one or more fully reversible symptom indicating a focal, cerebral or cortical or brainstem dysfunction. If it's a visual aura, it is your occipital lobe. If it is a brainstem involvement, they will have signs of vertigo, dizziness, ataxia, diplopia. If it is a cortical area, we will have hemisensory symptoms or transient hemiplegia. So it depends on which part of the brain is involved physiologically. At that time, the symptoms of aura will appear. The aura should last for more than 5 minutes. And this 5 minutes criteria is to differentiate between a TIA or a sensory seizure. The aura should last less than 60 minutes and headache should follow after 60 minutes. So this is a classical definition of migraine with aura. A figure here we can see that at 0 minutes there is some form of scotoma here. There is a scotoma developing here. Gradually at 7 minutes the field of vision is impaired and there are more of haziness in the vision, scintillating lights. The lights are rainbow color. At the end of 15 minutes there are typical rainbow color formation of lights, and then by the end of 25 minutes it is having difficulty in vision on one side. So this is a aura picture described by a patient. Many times patients say that they are having hemifield neglect. They cannot see on one side of the field, or they have a scotoma where there is a blind spot. Treating a patient of migraine, this is the most important slide. If you can take anything from my presentation, is this slide. Always reiterate or always please re-emphasize on these 3 things. One is abortive treatment, an acute attack for abortive treatment for an acute attack. Second is a prophylactic treatment where the patient requires to take the medication daily for at least 3 to 6 months. And lastly, most important is lifestyle modification, which no one emphasizes. An acute attack, we give NSAIDs. Naproxen is one of the most common drug, ibuprofen, aspirin, paracetamol. For more severe forms, triptans are given. Sumatriptan, your headset, that is given 25 to 50 milligram. Now, because of patients who are traveling or working class people, rizatriptan is available in sublingual form, so that can be easily taken. And in patients, especially pediatric population, zolmitriptan can be given by nasal spray. Ergotriptan, like old age brand name was Vasograin. So ergotriptan, ergot preparation are not commonly used nowadays because of a lot of side effects like hypertension and cardiac illness. Who requires a prophylaxis medication? Someone who has more than 3 attacks per month or very disabling attack. Even if it is 1 or 2 attacks, the patient may lose 48 hours, 72 hours because of the pain. Such patients require prophylaxis treatment. There are multiple options. Most commonly we use beta blockers, tricyclic antidepressants. Here of course we see the comorbid conditions. If a patient is having depression, anxiety, insomnia, tricyclic antidepressants or SNRIs like venlafaxine, duloxetine, amitriptyline, these can be used. If the patient is having tremors, hypertension, a propranolol can be used for prophylaxis. If a patient is having some epilepsy syndrome, if the patient is having some weight gain, then topiramate can be used because of its added advantage. So depending on the patient beliefs, patient's preference, your opinion, we can categorize, we can ask the patient to take the appropriate medication.
Dr. Manan, you need to summarize fast.
1 minute, sir. Lifestyle modification, avoid triggers like sunlight, noise. Here I want to focus on food. Chinese food or food containing Hajinomoto, which is common in our Indian preparation, that is containing monosodium glutamate. Those food items should be avoided. Not necessarily that every patient will have such triggers all the time, but maybe you can have a headache diary where you can note that these patients will have what is the trigger form of the migraine, and by noting down the trigger we can know which triggers to avoid. Headache diary is very useful because headache is something which we cannot measure. This is the only way to monitor whether our treatment is effective or not. So lastly, I would like to summarize that most common complaint in our OPD practice is headache. Out of those, most of them are primary headaches, and out of those, most of them are migraine. Important to know the history because a lot of patients have overlapping causes like migraine and sinusitis, migraine and glaucoma. Identifying the red flag signs, which patients require referral, which patients require urgent intervention or imaging. It is important to use the criteria to diagnose and classify the migraine or other headache forms so that appropriate treatment can be given. Always focus on lifestyle modification. Thank you very much.
If anyone has question, please ask during lunch time.
Okay.
Dear friends, let's stand up and clap loudly for such a lucid presentation by Dr. Manan Mehta. Now, I welcome you down the stage for the felicitation, for which I request Dr. Jagdish Patel sir to present the memento to Dr. Manan Mehta. I welcome Dr. Mihir Dholakia sir on the stage for his talk on orthobiologics, the new frontier. And I request the chairperson to introduce Dr. Dholakia.
I, Dr. Uma Naik, feel very privileged to introduce Dr. Mihir Dholakia. He works in the Zydus Hospital and has got a special interest in primary and complex joint revision surgery. But his topic for the day today made me really open up and read what are we talking about, orthobiologics, the new frontier. I thought orthopedic surgeons always loved cutting and suturing and other things, but this is using simpler methods, biologic methods for biologic problems. Over to you, Dr. Dholakia.
Thank you so much. Good afternoon, one and all. Thank you, Chairperson, Co-Chair. I first of all thank the patrons of IMA, the organizing committee, and all the delegates for coming here. Orthobiologics as a topic has been under study for about 20 years. Before I start, I need to tell, I just noticed that all the three speakers who were there, it was Manan, Mihir and Ravish will come. So it's MMR, so we have the very senior most pediatrician there, plus Kalpit Bhai, my senior colleague, and Jagdish sir. So just by the way, I just realized it was an MMR thing. Okay, so orthobiologics is a topic where it's been in study for about 20 years. And it's a part of the regenerative medicine which has come into vogue. So in 3000 BC, as per Mahabharat, the Adi Parva, chapter 114, Shlok 17, the Kauravas were created by a boon given by a sage, and they were, given a pound of flesh, and from that flesh they made 100 pieces or 101 pieces. And probably that was the time when that was the beginning of the embryonic stem cell. So we can consider that as the beginning of the orthobiologics then. The past 20 years of medicine has been an unprecedented area for the rate of scientific discovery, providing a greater understanding of the disease pathology and processes, eliciting a new area of medicine called orthobiologics. We're going to revisit a little bit of basics in this. They are basically derived materials which aim to promote the regeneration of tissues that are the focus of orthopedic surgery. Obviously, we deal with plates, screws, joints, and so on and so forth. So obviously, there's too much of focus on joints nowadays, spine, trauma. Obviously, that's there. But this is something which everybody would, wish to do if they can prevent a surgery. The biological characteristics of these materials rely on the substance that are naturally present in the blood. They may include injuries to the muscle, tendons, ligaments, or more chronic conditions such as osteoarthritis. The treatment may decrease the need for pain medications and accelerate the healing and improve the recovery. So what are the unknown things which are there? Some people heal better than others. We don't know why. There are certain organs regenerate and repair on their own. We don't know why. Can human body's inherent regeneration potential can be harnessed? Yes, now it can be under research. And what would be the potential fallouts? So what are the cost to benefit ratio? What are the ethical issues in all these things? The approval issues from the DGCI and the FDA and all those bodies. And the moral issues of these, the orthobiologics. So coming to the basics, the sources of stem cells in the adults are the hemopoietic stem cells, the mesenchymal stem cells, we have the neural, we have the muscle derived, we have the pancreatic, hepatic, epithelial and dental. Also, we have the fetal tissues. Nowadays there is always a harnessing of the amniotic membrane or the amniotic material for orthobiologics. As everybody is aware about the cord blood which is there, which some people harness, and there are companies making it possible for them to preserve for about 60 years or so. Then there are embryos which are there, and then everybody, I think probably they must have read about it, is the adipose derived stem cells, which is the SVF, which is a stromal vascular fraction, or the Sahaj, as you know, which is there. So what are the spectrum of products that we have in orthobiologics? Either you can have a simple bone graft. So if the fracture is not uniting, then you have a bone graft which is there, a cortical or a cancellous bone graft. If there is a tendon rupture, you can transfer a tendon, you can have a tendon graft. You can have a PRP which is there, which is platelet-rich plasma, or you have a BMA which is bone marrow aspirate, or a mesenchymal stem cell. The old school allograft had a cancellous, they were used as a cancellous void filler. They had structural cortical grafts, that the osteochondral graft for defect and the tendon, and then there is a degeneration bone matrix. The ceramic or synthetics available were injectable calcium, phosphate, sulfate or hydroxides. The bone morphogenic proteins, especially the BMP2 and the 7, which are more important. The new school allografts which are available, the placental or the embryonic tissue, and the most biologic are classified as devices, but orthopedic surgeons don't consider these as devices. So these are the spectrum of choices that you have, right from the calcium triphosphates to the PRPs to the BMPs, the hyaluronic acids to the other to the BMPs for the spine, the calcium triphosphate to the cancellous bone grafts, and this is BMAC, the bone marrow aspiration concentrate. So their healing trinity is formed of three things. We have the adult stem cells. We need something for the stem cells to make a scaffold, whether it is synthetic or it is natural, and then the growth factors which are there. Fracture union, non-union has been the most troublesome due to the improper alignment. So we'll come to bone, tendon and cartilage. So fracture non-union has been the most troublesome due to the improper alignment, inadequate instability or inadequate stability, circulatory problems or metabolic disorders, and critical size bone defect. Now you can't expect somebody to inject into the bone defect if the defect is so, somebody has kept a defect which is so large, and you can't expect them to heal it with some injections. So you obviously need some grafts, or you need some proximity of the bone to be there. So bone grafts which are oldest and most studied are through processes of osteoconduction, osteoinduction and osteogenesis. And the allograft which are used, they are basically, the hype is obviously they use as a void filler, they have an osteoconductive matrix, and they have small amount of growth factors. This is a level 2 and a level 3 data study which is available. The other available thing is for the void are the BMPs. They are really readily available bone void fillers with growth factors, but there is no level 1 or 2 human data study in this. So osteoconduction, it's a passive process. It is used as a porous scaffold and allows ingrowth of vascular tissue with the MSCs, mesenchymal stem cells. Osteoinduction, it aims to recruit pluripotent adult MSCs, and they can differentiate into osteoblast and the chondroblast. And osteogenesis is the new bone which can be synthesized if a graft contains variable donor osteoblasts or the precursors. So this is a chart which will tell you that which is the best osteoconductive, osteoinductive and osteogenic. So as you know, the gold standard which is there is our own autografts or the bone marrow aspirate which you can get from us. The rest are all synthetic, which have, some don't have osteogenic, some don't have osteoinductive and some don't have osteoconductive properties. So bone allografts, although the methods are free of drawbacks, the sterilization process is, so we have bone banks, but there are so many problems with that with regards to legalities. We have only a few bone banks. We have only one bone bank in Baroda, but that is also probably not functional. So most of them are got from Tata Memorial or from a place in Ahmedabad. And there is a risk of bacterial and viral infection as well. So then we come to the autologous bone marrow aspirate. It is a classical technique. It stimulates bone growth and angiogenesis. It is obtained from the iliac crest. It has got osteoconductive and osteoinductive properties. The allogenic MSCs can be used effectively, and use of extracellular matrix and preserving its structural and bioactive elements after decellularization and treatment are in use. So that's the machine that we use for the separator. Either you can have, once you withdraw the blood from the iliac crest, you can, or you withdraw from the cubital vein under sterile conditions. You put this and in a different RPM, BMAC or a PRP is separated, right? So it depends on the company and it depends on the kit. This is the kit for the PRP which is being used. Then that is after withdrawal it is put, and this is what you get. So you have the buffy coat, and then you have the PRP, then you have the PPP, platelet poor plasma, and then you have the red cells. So you just take about that aliquot of 3 to 4 ml and then you inject in the body wherever you have to inject. So this is the bone core decompression for avascular necrosis. Everybody is facing that. Post-COVID steroid-induced avascular necrosis of the hip. So we do a core decompression, and then that void needs to be filled. So that void is then filled by bone graft, and it is supplemented with a BMAC, bone marrow aspiration concentrate. So then that is the bone graft which has been filled. And then you do a repeat MRI in about 6 months time and see whether the stage has increased or not. So it's a 60% effective. It's not foolproof, but it is joint saving. The other things which are available are calcium triphosphate and BMP, such as BMP2, BMP7. There are now nails coated with BMP and ceramic materials which are available. But the problems that can happen are they may have heterotopic ossification, seroma formation, wound issues, and they themselves need activate osteoclasts, and hence you can lose bone, and there is a resorption. So these are the things that we just talked about. They are again void fillers, calcium carbonate, phosphate, triphosphate, hydroxide and calcium sulfate. The same thing there. So then they tried bisphosphonates, because bisphosphonates are tried with BMP to reduce the site of BMP. So we just realized that osteoclastic activity can increase with the BMPs. So you add bisphosphonate, which are osteogenic in nature, and hence they reduce the osteoclastic activity. The PRP, which is derived from the blood, is then centrifuged, and various techniques are there. And how does it benefit? So it has got platelet derived growth factor, it has got transforming growth factor beta 1, it has got epidermal growth factor, it has got fibroblast growth factor and insulin like growth factor. So it enhances stem cell recruitment, angiogenesis and extracellular matrix production. It's a small bag in which it comes. BMP, it's a long awaited holy grail of orthopedics, and it's in use for avascular necrosis, and it is effective. The gold standard obviously is the bone grafts. Then the autologous bone marrow aspirate, there is another which is available, which is recombinant parathyroid hormone or teriparatide, which is available. It acts on the osteoblast and osteoclast to resorb bone and increase the serum calcium. Now the common problem which happens is with certain people is that the proper alignment of bone is not done, and then they prescribe these medicines thinking that the injection will help them unite That's a very wrong notion. So it is not the case. You have to have a good surgery done if you want the fracture to be united. You just don't inject anything. Another molecule is a NEL-like molecule 1, which is NEL1, which has been shown to enhance bone growth and repair. It has the same signaling cascade as the BMP. Ligaments and tendons, as you know, the ligaments are avascular, intra-articular like anterior cruciate ligament in the knee. So you just can't inject a torn ligament and you expect the ligament to heal. So we have to operate on it in a younger patient. So ACL reconstruction is the gold standard, and adding PRP to ACL has no added advantage. Hence somebody telling that, oh, we'll add in PRP, it will help, is I think farce. But there is a study for tendo Achilles where a PRP and a BMAC is used, so that improves the quality of the tendon and it may help it to heal. Rotator cuff impingement and augmentation by PRP also has got poor results. Future research is channeled to focus on combination of nanofiber scaffolds and stem cells. Entheses, which is improved by the double matrix. What is enthesiopathy? Wherever a tendon attaches a bone and you have pain there, so trochanteric bursitis or radial styloid or ischial bursitis or Achilles tendinitis or retrocalcaneal bursitis, all these things which are there, they can be improved, but again the maximum effect it has is in lateral epicondylitis, or people consider it tennis elbow, and plantar fasciitis. That are the only two which are proven about more than 85 to 90% effective. Rest is about 50% effective. Cartilage, it is a natural intrinsic healing capacity of arterial cartilage is limited. The goal of repairing tissue to resembling hyaline cartilage and improve loading. So what can you do to improve a cartilage? If there is a defect and when you are doing arthroscopy, you can do a microfracture. So you actually drill into the bone so that there is a bleeding. The bleeding converts itself into a fibrocartilage, but it is never going to be converted into a hyaline cartilage. Then you can do an OATS, the osteochondral allograft transportation. So you take from the non-articular area and put it in the defect area. And you have an ACI, which is autologous chondrocyte implantation. All these sports people get this done, and it is reviewed after 6 months whether the scaffold is developed or not. But these all produce fibrocartilage and not hyaline cartilage. Use of PRP in cartilage healing with leukocyte concentration of PRP with an efficient delivery system is also under not too much a solid support. The chondrocyte sealed scaffolds and matrix induced ACI, where the donor site chondrocytes or MSCs are seeded into scaffolds made of hyaluron, bio-reabsorbable polylactic and co-glycolic acid polymers, or agar-rose alginate hydrogels. So when you see, these are complex names, but when you use them and you just have to open the cartilage defect, clean it up and inject in it, it will form a solid thing with fibrin clot, and then that is converted into a hyaline cartilage. Mechanical loads or hypoxia are also necessary to stimulate chondrocytes. The complex regulatory requirements are one of the reasons to slow down the advancement of cellular therapies. So not necessarily, as everybody would agree, anything new and fancy is good. So the clinical data which is supported, which is shown by the companies, is this, but what we actually get is this. Amniotic fluid products, yes, cell therapies are there, but again it is not very encouraging. From the American Orthopedic Association of Orthopedic Surgeons and the National Institute of Health, the optimizing clinical use of biologics in orthopedic surgery, they have done a warning that misinformation for marketing of largely unproven biologic treatments may erode the public trust, and the responsible investment needed to bring legitimate biologic therapies to patients, minimal standards for product characterization and clinical research. So compliance is a big issue with these things. So it is not that anything new should be used. In conclusion, rather old concepts, but research on orthobiologics is richer and more accelerated than has ever been. Orthobiologics hold a greater potential to unfold a new chapter in clinical orthopedics. Thank you so much for your patient listening. I am happy for questions anytime.
Thank you. Now I request all the audience, let's follow our new normal. Please stand up and clap loudly. Now I welcome you down the stage for the felicitation, sir. I request Dr. Uma Nayak madam to present the memento to Dr. Dholakia sir. Now I welcome Dr. Ravish Patel sir on the stage for his talk on why spine surgery fails. And I request the chairperson to introduce sir.
Hello. Welcoming Dr. Ravish Patel here. Dr. Ravish Patel is an orthopedic surgeon by profession, fellow in spine surgery. Interest area is minimally invasive spine surgery, endoscopic spine surgery, and spine deformity correction. There are many achievements. Some of the achievements I will list: more than 15 PubMed indexed publications in esteemed journals like World Neurosurgery, Spine, European Spine Surgery, British Medical Journal, SRS Global Outreach Program Scholarship Award in 2019, and prestigious Indo-American Spine Alliance Fellowship Award 19. Well, adding something to Dr. Manan's lecture, he showed so many causes of headache, but he did not mention one, that backache to a patient is our own main cause of headache, right? And whenever somebody explains the patient that you need to undergo some surgery for spine, the only universal reaction is no, I'll never go for surgery of spine, it always fails. Then we have to answer him very smartly. I request Ravish to give us that answer. Dr. Ravish, please.
Okay, thank you. Thank you for a warm introduction. And it's close to lunch, so before the smell of tasty dishes mesmerizes you, let me go take you through something which is very important. So today I'll be talking about why spine surgery fails. Now the oldest evidence of a spine deformity correction was when Lord Krishna corrected the deformity of Kubja, and this was some 5,000 years ago. And today, after lot of technological advances, lot of progress in the field of science, today spine surgery still has a social stigma. People believe that spine surgery will cause neurodeficit, spine surgery will make them paralyzed for the rest of their life. Now the question is, do spine surgery really fail? And if they are failing, why are we doing them? So let's look at the literature. Now here I have compared spine surgery, a single level fusion surgery, with that of an hernioplasty or a knee replacement surgery. You can see the complication rate that requires a revision or an intervention is almost similar. Yes, you can argue that in spine surgery you can get paralyzed, but you can never get paralyzed in an hernioplasty or knee replacement. So let's look at the quoted rates of neurological deficit. You see these are very small, like it varies from 0.2 to 3%, except in cases of complex deformity where the rates may be higher. So the failures are not that common as we think. In fact, majority of the spine surgeries have a really good outcome. The next question comes, then why is this perception that is created that spine surgery fails? Obviously, there are failures with every surgery, and there are few reasons for a spine surgery to fail. So let me take you through the reasons. I have divided the failures into 4 types. The first one is a type 0 failure, where we fail to recognize the exact cause, and that can lead to failure. And it is important to know that any patient having a back pain or neck pain may not be coming from spine. There are other causes also. For example, a gynecological cause can also give rise to back pain. Renal stones can also give rise to back pain. And sometimes problem in hip joint can also give rise to back pain. As in this case, the patient had undergone a spine surgery, was not happy with the result because the patient was having a hip arthritis. Similarly, there are many cases where problems at L4, 5, alpha S1 are associated with sacroiliitis, and they may hamper the results and outcomes of the surgery. Now, if you ask any neurophysician, they will definitely tell you that they have seen many patients where the spine surgery has been done, but the patients have not recovered because an underlying neuropathy was not identified before the surgery. And I think one should always, look for neuropathic or neurological causes before jumping the bandwagon on spine surgery. And rarely, there may be vascular causes which can actually mimic a spine pathology. Now, this is all one end of the spectrum. The other end of the spectrum are the missed spine pathologies. You see this patient, a normal looking X-ray was sent with medicines at home, and when the patient did not improve, when the patient came to us, we diagnosed that this patient was actually having a spinal fracture. And fortunately, this was picked up on time. Otherwise, this patient would have landed up in paraplegia soon. Sometimes we do get patients like this. Here, multiple fractures in a 50-year male patient. The patient, the doctor thought that it may be because of the cord compression that he is having symptoms. He underwent a laminectomy. The symptoms did not improve. And when we investigated, this patient was found to have a multiple myeloma, and he got better with just chemotherapy. So the first message that I would like to give is that we should not jump directly on surgeries. We should evaluate a patient clinically, thoroughly, and there should be a clinical radiological correlation before jumping onto the surgeries. Now, the other type of failures are when we know what is the cause, but somehow we miss the bullseye. So that can be the second reason where a patient may not have an adequate outcome, and these are the cases where there are inappropriate or inadequate surgeries done. So now the inadequate surgery may be in form of an inadequate decompression where the primary cause was not addressed, or when the decompression is very good, as in this case of spinal tuberculosis where excellent decompression was done, but what was not addressed was the biomechanical stability. And so in spite of neurological improvement, this patient never was able to walk, and it's only when this patient underwent a reconstruction, he regained ambulation. Sometimes it's very difficult to identify instability on an MRI, and that's why we go for special X-rays known as dynamic X-rays, which help us to identify whether a patient will require a fixation or not. There is a unique problem in spine. You know, you have seen cataract, wrong side cataract surgery, right or left side, wrong side TKR, but in spine we have a problem known as wrong level surgery also. And that's why we must be very careful, because the radiologists, they start counting from the top. And so the last level may not be same in all the patients. So, and during the surgery, we have the help of an X-ray. So it's very important to correlate the X-ray with that of an MRI. Otherwise, wrong level surgery may jeopardize a good outcome after the surgery. Sometimes the screws go haywire. Here the screw is in the spinal canal or in the vertebral artery. That can also jeopardize the outcome of a spine surgery. Now, spine surgery is very complex, and one has to hit the bullseye all time. You know, it's not only about decompression, it's not only about fixation, but you have to address the biology also. Here, the patient was decompressed properly, the patient was fixed properly, but what was not done was the biology was not addressed, bone grafting was not done, and this patient ended up in failure. And this could have been prevented if there would have been a proper bone grafting in this case. There are many technological advances that are occurring in spine. And this was the photo, this is the photo of a laminectomy, discectomy that surgeons used to do 15-20 years ago. And now there are significant changes that are occurring, and the today's spine surgery, you can see even the open surgery, we do very minimal resection, because now we understand the biomechanics much better, and now we are able to conserve and preserve most of the tissues, which was not possible in the past. And it is because of this that the world is moving towards minimalization, and the results are really beautiful, that the patients are even able to walk 2 to 3 hours after surgery. They are able to go home on the same day or the next day. Third set of failures are the early failures, and majority of these causes are beyond the control of a surgeon, and the causes like infection, arachnoiditis, even stroke and pulmonary embolism can also occur in spine surgery. So here, the best thing as a medical person we can do is to diagnose this problem early and treat them on time so that these patients can get back to life. And it is said that a stitch in time saves 9. And this classical example, a patient having a post-operative infection was treated with just oral antibiotics, waiting for it to heal. And when this patient came to us in this condition, looks very terrible, but we got this treated by repeated debridements and VAC surgery, and ultimately the infection got settled. Or we may have a patient like this where a slip disc herniation surgery was done. The patient may have a recurrence after 3 months, and we have to revise and fix it because the patient was a farmer and he wanted to do all sort of farming activities. So here, just because both these patients are treated on time, they are still ambulatory and they are still well, they are doing their work nicely. Certain failures are because of the aging process. As in this case, this patient underwent an alpha S1 surgery 12 years back. He was happy for 12 years. After 12 years, he develops an adjacent segment pathology because that level has started to degenerate, and ultimately we had to revise after a span of 12 years. Sometimes you tell patients to follow their rehab very strictly, but most of the times they do totally the opposite. They don't follow. And that's why there can be delayed failures, or there are patients who have totally unhealthy lifestyle which are not good for not only for their spine but for their general well-being as well. And I would say that there are 3 killers when you look at the systemic diseases that can jeopardize a nicely done surgery. These are smoking, diabetes, and osteoporosis. And the classical example is this case where an obese diabetic smoker underwent this spine surgery. He didn't quit smoking, develop a non-unilateral L4-5. Ultimately, we have to revise him with a bigger cage, and as Mihir sir mentioned, we have to use biologics BMP in this case during the revision surgery. There are many things which are not in our control, and the best example is a paraplegic patient after a road traffic accident. Here the results are poor, the outcome is not that great, and we can't do much about it, but we can still try and give the best care to the patient. And second are the patients that present to us very late. You know, most of the time in Indian scenario, the patients comes to us only when they have a neurological deficit. And this is very late as far as, you know, if you want a good result, the patient should come to us on time before they actually develop a neurological deficit. So what is the solution to this problem? This is what we do at our center. We follow a TIMS protocol. So T stands for timely intervention. We do a timely intervention whenever a patient comes to us which require intervention. We follow evidence-based medicine. We try to gather evidence from all across the globe, and we use it for the benefit of the patients of Baroda and Gujarat and even Madhya Pradesh. This is the most important point I would like to highlight is avoid unnecessary surgery. 95% of the patients that come to our clinic, they don't require surgery, and I think that this should be stressed, that avoiding an unnecessary surgery will reduce the number of bad outcomes. And whenever a patient requires intervention, what we do is we go for a minimal invasive intervention. We try to avoid a surgery like this and do something with very small incisions so that the scar is small and the recovery is very fast. And last, what we follow is a safe spine surgery. You know, in our OT, we are spoiled by Dr. Bikhubai. We have all the advanced cutting edge technology which we use for safe spine surgery, and it is because of that we are able to provide all the components of a success, what is required for a successful spine surgery, be it minimal invasive surgery, where we respect the biology, we can restore the biomechanics, we can restore their alignment, and do a proper rehabilitation for a good outcome. And it is because of this policy that we follow, we have good number of cases where not only the patients have improved, but they have got back to work. So at the end, yes, I would say that if a surgeon says that he does not have complication, trust me, he is not operating. Every surgeon has some complications, but the trend nowadays is that spine surgeries are getting safer. Neurodeficit after spine surgery is a rare event, and incisions are getting smaller. Thank you.
Thank you, sir, for the crisp talk. Let us follow our new normal. Please stand up and clap for the sir.
Thank you.
Now I welcome you down the stage for the felicitation, for which I request Dr. Kalpit Bakshi sir to present the memento to our Ravish Patel sir. I also welcome all the chairpersons down the stage for the felicitation. I request Dr. Shravan Dave, Dr. Asutosh Singh Rathore and Dr. Nilesh Makwana to present the memento to our chairpersons. Friends, to chair the next session, which is the last session of the day, I invite Dr. Mahesh Bhatt and Dr. Jayesh Tripathi sir on the stage. Dr. Mahesh Bhatt is a senior pediatric cardiologist and Dr. Jayesh Tripathi, a very senior physician practicing in Vadodara, on the stage. Now I welcome Dr. V.C. Chauhan sir on the stage for his talk on recent advances in cardiology with case-based discussion. And I request the chairperson to introduce sir.
You can do that also.
Forward, no?
Yeah, forward.
Backward.
If you need a presenter, you have this also.
Dear friends, it is indeed a pleasure. I am sure you all will agree the new tradition which Dr. Bhupendra Kapadia has started, new normal. In the same way, in the last lecture, I would utter the word as a new normal. That is the real exclamation for this wonderful Gimacon conference. I am sure you all will agree that the science beyond the speciality, which is delivered by all of our learned speakers, was really awesome. What can be a better option to complete the conference than to have a cardiologist, Dr. V.C. Chauhan, as one of the last guest speaker. You all know that he is an adult cardiologist for more than 2 decades with Bhailal Amin Hospital, and he is MD Medicine, a fellowship in interventional cardiology as Australia, I suppose. His areas of interest are coronary interventions and structural heart disease. He is a real academician. He was the first one as a cardiologist to do angiography and renal angiography in Vadodara. He is the first one in Gujarat with Dr. Vijay Thakur sir to do carotid angiography. Has done 4 TAVR, that will be the second lecture, with Protectors in BAGH team, and he is faculty in many national and international cardiology conferences. So let us listen to a learned adult cardiologist, Dr. V.C. Chauhan.
Yeah, thank you very much for kind word. And like all my previous speaker, I would also like to extend my thanks to the Gimacon and IMA Baroda. But unlike all others, I can say I'm the last person. So whatever applaud I have is the most reliable, because it's a conference is almost coming to the end. And I agree that at the moment there are very few people present. It was one of the biggest and the most successful conference we ever had in Gimacon. So that is great. Now I'll just ask you why Bhajap is successful. Can anyone say why Bhajap is so successful? Yeah, teamwork, but more important because they have Shah, Amit Shah, who is one of the best strategics, best planner, best organizer. So how can we fail? We have 3 Shahs, Pragnesh Shah, Mitesh Shah and Samir Shah. So that is the reason why we succeeded so well. So I really give loud applaud to all 3 Shahs and definitely Chetan Patel and other IMA members. And I think that is the reason for success. Before my lecture, I had 2 fears, whether I will be seen or not. But yesterday when I see Vijay Thakur, half of him above the podium, my fear disappeared. So that is also a very good thing. And thanks to all the people who are still present at the last moment. My biggest problem is, of course, to talk about recent advances in just 20 minutes, and that is most difficult. See, once when Winston Churchill was asked, sir, can you give a lecture for just 10 minutes tomorrow? He said, oh, I can't, I need 1 month to prepare. But if you want me to talk for 1 hour, I can talk even right now. So that is my position at the moment. To talk for 20 minutes is very difficult. But let me, this is a topic that I had in my mind about the progress in coronary imaging, about the progress in coronary interventions. Yeah, we have a lot of new stent device, 3rd generation stent, biovascular scaffold, which actually disappears within 2 years and there is no more stent, vessel come back to the normal. We have special bifurcation tank and lot of new technology to deal with the bifurcations, covered stents, mesh stents. Also there are solitaire thrombosection devices for intracranial procedures, special thrombosection devices to deal with the very heavy calcium, rota ablation and intravascular lithotripsy, which actually learned from the urologist. And because of this thing, we have a lot of expanded indication of percutaneous interventions, like in past left main lesions, bifurcation lesions, calcified lesions, they were dealt only by the surgeons, but now a lot of interventions are done by the interventional cardiologists. Also we do a lot of procedures post-surgery in surgical grafts or Lima grafts. Also we deal with long lesions, chronic total occlusion. So in general, there is a lot of expansion in indication for the angioplasties. Also there are a lot of new procedures like TAVR, left atrial appendage devices, mitra clips, percutaneous mitral valve repair and replacement, pulmonary valve replacements. In general, the technology has progressed to a huge extent. We have now CRT-D device, extended indications, leadless pacemakers, parachute device, and a lot of invention and advancements taken place in medicine. But medicine, I don't know whether we have enough time or not. Just can anyone identify any of this? Just because we are talking about advances, we should not forget the root people who actually made these advances possible. Just if you can. This is a William Einthoven, the one who invented the ECG machine. So when the first ECG machine came to Gujarat in 1950s and 60s, it was a big surprise. People were surprised, how can you diagnose heart attack just with some machine like this? And it remained a surprise for almost 1 decade or so. He's a Gunzig who is the first one who did the angioplasty. That was in 1978 or so, and the patient is still surviving. And at that time, it was a very crude method, but now technology has progressed a lot. And this is Werner Forsman. He himself put a catheter in his own body and proved that from peripheral vein you can reach the heart. He was removed from his college at that time, but after 20 years he got the Nobel Prize for one of the first intervention procedures done. We have a lot of progress in bypass also, like complete arterial grafting, beating heart surgery, minimal invasive surgeries, and safe robotic surgeries. Bypass surgery in majority time without blood transfusions. Same way we have a lot of investment, advancement in cardiology, in interventions. But of course, whenever we have new technology, we get new disease and new problems also, which were never heard before. As for example, acute and subacute stent thrombosis, which was never heard of before, in-stent wrist stenosis, stent-related aneurysms, radial or Lima artery spasm, attrition. So we have to deal with new technology, and obviously we have to deal with new problems as well. Just I am showing this how the technology has progressed. Like I went to attend one conference in South Korea, Seoul, and there's one of the huge Pleasant Park. Can you see this theme park? And there was a big ditch there where I'm standing. And after 4 years when I went, there was a huge building, just taller than the Empire State Building. So what I have to say, there is a tremendous progress in each and every sphere of our life. But most important is in technology, in medicine, there is a maximum advancement, and India has catch up with the rest of the world. Baroda has catch up with the rest of India. While in rest of the technology, we are still 1 or 2 decades behind. So I'll just go into detail about physiological assessment. We do multiple tests. The new one is FFR, rest other thing you know, and imaging also you know everything, but I'll just go into very brief detail. Now see, this is one of the doctor colleague of ours who had present with typical exoangina, a very tight lesion in circumflex and lesion in the right side. So I was planning angioplasty for circumflex followed by angioplasty of right. Would you agree with this or not? This is a right coronary artery which I thought we should do angioplasty for, and this is a circumflex artery. So obviously, I fix the circumflex. Now what should you do? Now coincidentally with doctor, there are 10 other doctors coming who must have attended my own lecture of FFR and said, why don't you do FFR right? Because it's looking borderline. So I reluctantly did the FFR, and to my surprise, FFR right was normal. So sometimes borderline looking lesions, we often do angioplasty or surgery, but when you do FFR, a physiological assessment, you avoid unnecessary surgery or intervention. He is doing well after 4 years, this lesion has not progressed. So this is just example. FFR is basically pressure difference between proximal and distal vessel, and it can help you decide whether to touch or not to touch borderline lesions. So with that you can reduce the number of stents, you can reduce length of the stents, you can convert 2 vessels into 1 vessel and 3 vessels into 2 vessels, and that is how you can reduce bypass surgery or even angioplasty, and that is the advantage of this. This all ultimately resulted to reduce complication rates, reduce death rate, and definitely improve the prognosis. So this is just example of one physiological assessment. This is how it looks even when there are multiple lesions. It can help us identify which lesion is culprit and which is not culprit. We have many other imaging modalities. IVUS and OCT are one of the most important at the moment. You can actually see the coronary arteries. If coronary is totally normal on CT angio, you can tell patient that probably 5 years is not going to get a coronary artery problems. And in those who are high risk, we can do this once in 5 years. It gives very good negative importance. And we do it nowadays even in emergencies, sometime when we don't decide what is there. IVUS is intravascular ultrasound. We can actually decide the plaque morphology and the character of the problems. As for example, angiography is on the luminogram. There are many areas where you feel angiography is normal, but actually you can see that could be lesion, and that is what we can miss if you do only luminogram. This is the reason why in angiography we often don't see the plaque, because it is luminogram, and unless there is a narrowing, it will not see it. If there is a positive remodeling, arterial lumen may still remain normal, but patient can still get heart attack in future. So don't reassure patient 100% if angiography is normal. With the OCT, that is yesterday, I think it was very well talked yesterday, but we can identify character of the lesion, whether it's a lipiduric, fibrotic, or even nodular calcific, and that helps decide whether we should do particular strategy for treating this patient or not. As for example, if it is a fibrotic, we can do direct stenting, but if it is very severely calcified as in last, we have to do IVL or rotablation or some of the atherectomy before we put a stent, otherwise stent will not get opened properly. So that is example of how the new technology can help us decide properly. Not only that, it also has to decide length of the stent, and even post-stent whether we have done proper job or not. As for example, in this, everyone would feel angioplasty is done and the result is good, there is no residual lesion. I am very happy with the results. But when IVUS was done, OCT was done, you can see there was a distal flap, dissection, and proximal stent malapposition. So both were corrected with additional stent and post-dilatation. So many times when angiography looks normal, sometimes other technology can say what is the limitation we had. When we do bifurcation stent, we can decide where the wire should cross. That also can make your result much better and successful. In short, with new technologies, we can identify malapposition, underapposition, age dissection, geographical miss, protrusion, and many other problems, and we can reduce actually complication rate of our procedures. So we do not want to now work only on a blind. That is the thing. With 3D, we can actually have real 3D views, and it can give much better results. So when we do imaging, it is like seeing the arteries from within, and that gives definitely much better results otherwise. We have a lot of advancement in interventional tools. I will just go into detail. We have much thinner stent, as for example, the first ever drug-eluting stent has 140 micron thickness, but now they are less than 50. The latest is even 40 microns. So thinner the strut, better is the long-term results. We have a lot of thrombosuction devices with which we can actually remove the thrombus, especially in acute coronary syndrome, when the artery is filled with the thrombus, as for example it is seen here. Because even if you do successful angioplasty, if the thrombus goes distally, the prognosis is worse. It causes a lot of immediate as well as long-term complications, and that's why we have to have certain technology like devices with which we can remove the thrombus. Once you remove the thrombus, TIMI flow improves. Either we avoid putting a stent, especially young people, or you can make a shorter stent. So that gives much better long-term results. So just small stent thrombus like this, 2 millimeter by 5 millimeter can kill a long, big, huge man. We have to remove the thrombus to make the angioplasty result much better. We have special devices like mesh stent, which will prevent distal embolization. Now this is another example of a very elderly lady, 78 or 80 years. Can you see heavy calcium in the vessels? In this vessel you can calcium even before the angiography picture is seen. So because patient was 78, relatives said let's go ahead and do. I said no, this is a case for rotablation, but they wanted to do it. So we started doing the case, and you can see this is the smallest possible balloon, that black dot. it just didn't cross. It's a balloon non-crossable lesion because of heavy calcium, which is very rigid, which didn't allow it to cross. So next day I did the rota ablation. Rota revolutes at 150 to 200,000 revolutions per minute, and with a diamond burr we can actually pulverize the calcium and make the artery big. It's like a sophisticated drilling. So we are not only plumbers, we are carpenters as well. So this is what we can drill. And next day, the large balloon could easily cross up to the distal. Of course, the large balloon also could not get open. So what would you do? I did another rota. This is larger balloon rota. So we made the hole bigger. And after that, we could probably open the balloon completely. Now you can see the balloon opens completely. And then you can do much better results. You can see this result compared to pre and post. You can see how much is the difference between pre and post. This is the example. This is another example where there was a significant calcium. He presented with unstable angina. Again here I did FFR. FFR was negative, so we deal with only right side, which you can see. Right side is such a diseased vessel there. So here again rota was done and made the way open, and you can see the difference between first and the second. This is the example of how rota can take care of. There is a before the rota and this is after the rota. So in general, we have many such examples. This is a patient who had a bypass surgery and presented with symptoms, and you can see left main very heavily calcified, but there is a very large vessel. So now we have new technology which is known as IVL. I hope you must have heard of IVL. And IVL is balloon with ultra shock waves. We can actually crack the calcium, and once calcium is cracked, we can put stent and it gives much better long-term results. So this is an example of how non-dilatable lesions can be taken care of. This is rota ablation, and this is OPN means very high pressure balloon. You must be surprised that when we do angioplasty, we give 14 to 16 atmosphere pressure to blow the lesion. But with OPN balloon, we can go up to 45 to 50 atmosphere of pressure. So it is such a surprising that in tiny coronary vessel we give such high pressure, but usually patient tolerate well. This is the technology. There is an intravascular IVUS which can actually crack the calcium with ultrasonic waves, and that is what results can be achieved afterwards. Now this is another patient who was just 38 and he has a significant anti-wall MI. So what would you do? Can anyone see this? Is there any difference between this stent and routine stent? This is an example of biovascular scaffold, the stent which dissolves completely within 2 years. So I did 5 such cases in those who are less than 40 years of age. So the advantage is patient will come back with almost normal angiography after 4 to 5 years. You don't need double antiplatelet agent forever, and that artery becomes almost normal afterwards. This is how the stent looks initially, but after 4 years is completely reabsorbed. There is no material, scaffolding material seen. So this is one of the new technology, and again I can proudly say it's made by Indian company, which is really great. We also do ostial LAD and left main lesions. This is a very typical example of left main stent. Left main was till this date surgeon's domain. This is another 84-year-old with critical left main lesion, pre and post angioplasty. You can see the difference. This is a pre and that is a post. So nowadays in a patient who presents like this with inferior MI, we first take an angioplasty and then maybe do angioplasty for the left main, which was reserved for the surgeon in past. Even bifurcation lesions, means critical left main bifurcation lesions are subjected to angioplasty nowadays. This is an example of pre and post bypass. And this is how bifurcation stent can look like. This is how we can use OCT and other technology to our use. Those patients are very sick. We use certain mechanical cardiac supporting devices like impeller devices, for example, or intra-aortic balloon pump. When there is a vessel rupture, we can cover with a papillary stent. So technology has created a lot of new problem, but it will also help us give answer to these problems. Very long lesion like this, we can take care of by 50 millimeter stent, which is really long stent. So in general, the subset of patient whom we do angioplasty is changed from single vessel to multi-vessel, left main, long lesion, bifurcation, etc., etc. And even chronic total occlusions are taken care of. Even post-bypass space, like as for example, there is a patient who has a critical lesion in SVG graft. This is a post-bypass patient who came with angina, and this is after putting a stent into the SVG graft. Similarly, here you can see, can anyone see what was the problem? This patient came 2 years afterward with exertional angina. Can you see any problem here? Can anyone say what is the problem? See, there is a critical lesion in the Lima graft. Also, there is a critical lesion in the left subclavian artery. So, both are diseased. So, what should you do? So, this is what we actually do. We put a stent in Lima. There is a stent now. And then we did angioplasty for the left subclavian also. So, this is example where we entered into the field of cardiac surgeon as well as vascular surgeon. And you know, entering into surgeon's field for cardiologists is like entering into lion's den. So it really requires a lot of courage and a lot of prayers if you want to really do some good job. This probably I think has been already talked, but you can say this is typical example of critical aortic stenosis, very calcified aortic valve. We always do the balloon angioplasty before to open the valve, and then we put a valve. We have two type of valve, balloon expandable and self-expand. This is an example of self-expandable valve. And this is how the tower is being done, which is another surgical area that we do. These are the two type of valves. This is a mitral clippage, for example, which you can actually, when patient is mitral regurgitation because of dilated heart or mitral valve, not rheumatic heart disease, we can actually clip. Of course, every procedure has certain limitations. This is a parachute device which we can put into the LV apex to reduce the aneurysmal left ventricle and related complications and the problems. Left atrial appendage device when patient has a huge clot in the left atrium in atrial fibrillation where you cannot give oral anticoagulants. Then obviously ASD and PSD closures are very common procedures that everyone knows it. But even VSD and PDA can be subjected. CRT device to improve the heart pumping. That obviously changes life category. Any patient with a severe LV dysfunction, left bundle branch block, CRT device must be considered. It makes a lot of changes. Leadless pacemaker has been already discussed yesterday. We have a lot of ablation therapy. Atrial flutter responds very well to ablation, but nowadays even atrial fibrillation can respond to cryoablation. Of course, this procedure is not done in Gujarat at the moment or even Western zone, but in Hyderabad and Delhi they do cryoablation at a pulmonary vein. It can control or even cure atrial fibrillation, which is really a big thing. Artificial heart valve has been already discussed yesterday, but the smallest heart was this. You can see the surprise how the smallest artificial heart can look like. Of course, I would like to say, whatever great technology we use, it's the man behind is most important, and whenever we start any new technology, we should know whether we'll end it or not and what is the thing. These are the two people who were inventor of the ultrasound, Helmholtz, Hertz and Egner. And nowadays we have LV strain. Many patients with really normal echo may have abnormal LV dysfunction which can be detected only by the LV strain. Our human eye may not actually pick up these problems. 4D echo has been now gaining popularity because we do a lot of structural heart like mitral and aortic valves, and it can give you a lot of new ideas which 2D echo may not give you actually. And that can overcome a lot of illusions we have. I think Tripathi Sahib is thinking different, but that is the hand of that man. That is a hand. So that 4D echo can actually find out what is the problem. We also do carotid angioplasty. As for example, this is a typical lesion, and that is what we can remove with the filter. And then this is an example of pre and post carotid angioplasty. A lot of TEVAR or vascular intervention has been done. That means Vijay Thakur has given very good example. So I don't want to give into detail about this. In general, it's never late to learn new technology, and we are all doing our best to learn new technology, and we are fortunate in Baroda. Almost all major cardiac hospitals are doing all the procedures that I mentioned. It's not only Bhailar but all hospital. A lot of advance has taken place in medicines, but I am not going to talk in medicine because we don't have enough time. This is the position of cardiologists in future when a lot of medicine will prevent atherosclerosis and we would not have any coronary lesions to do interventions, and we'll be playing games and just giving medicines. So I will just end here because the topic was too long. So if there is any question or any other suggestion.
Thank you, sir, for the excellent talk. Now I request audience to please stand up and clap loudly for the last session of the day.
Everybody keep clapping. Everybody keep clapping for 1 minute for the organizers.
Now I welcome Dr. V.C. Chauhan sir down the stage for the felicitation, for which I request Dr. Jayesh Tripathi sir to present the memento to sir. I also welcome our chairpersons down the stage for the felicitation, for which I request Dr. Samir Shah and Dr. Suresh Damor to present the memento to our chairpersons, who are the last batsmen of Gimacon 2022. Dear friends, please be seated for the valedictory function. I request everyone, please be seated for the valedictory function. I request our organizing secretary, passionate Dr. Pragnesh Shah, to give vote of thanks.
Dear friends, now it's time to say goodbye. A successful conference under the visionary leadership Dr. Mitesh Shah and great team efforts of all the members. કદાચ IMA લેવલ ઉપર આ એવી કોન્ફરન્સ હશે કે જેમાં મેક્સિમમ ડેલિગેટ રજિસ્ટર થાય. ઓલમોસ્ટ વી આર રીચ ટુ 1150 ડેલિગેટ્સ અને કાલે રાત્રે મેગા ઇવેન્ટ જે અંકિત તિવારી નાઇટ્સ એટેન્ડેડ બાય ઓલમોસ્ટ 5000 પીપલ. કદાચ આઈ થિંક એવી ખબર પડી કે પાર્કિંગ 1.5 કિલોમીટર સુધી દૂર હતું. અને ધીસ કોન્ફરન્સ ઇઝ એ ટીમ વર્ક ઓફ ધ ગ્રેટ યુનિટી. નાઉ આઈ રિક્વેસ્ટ ડૉક્ટર ભૂપેન્દ્ર કાપડિયા ટુ ફેલિસિટેટ ઓલ ધ key person of the conference. Yes, Dr. Bhupendra Kapadia. Thank you.
Dear friends, we all know that every good thing has to come to an end, and we have an incredible ride all throughout, isn't it? I just want to end it on the right note. It's a grand end of our own Gimacon 2022, which is packed with excellent science, grand mega musical event with Ankit Tiwari, along with socialization. It's because of the hard work of our organizing committee, Gimacon 2022. So friends, it's time to felicitate the heroes behind the curtains, the secret superstars, our dedicated in charges of all different committees of Gimacon. To recognize their work, I am requesting our leaders, magnificent President Dr. Mitesh Shah, passionate organizing secretary Dr. Pragnesh Shah to come on the stage, charismatic Dr. Chetan Patel sir, secret superstar Dr. Samir Shah sahib, macho man and Mr. BMC Dr. Mehul Desai to come on the stage. Friends, please give 3 big round of applause to all of them. Friends, success is not an accident. Success is not final. Failure is not fatal. It's the courage to continue that counts. Success is of everyone, and failure, if at all it may be, is purely individual. We all have gone through various ups and downs all throughout the journey of Gimacon 2022. We all have witnessed the hard work put in by all our committee members. We have fought efficiently against all different challenges, may it be finance, faculty, science, culture and socialization. Now, the time to felicitate all our organizing committee members. I request all of them to come on the stage very fast. I request Dr. Mitesh Shah to give a felicitation memento to our co-chairman Gimacon 2022, Dr. VC Chauhan Sahib. Dr. VC Chauhan sir, please come on the stage. Then our another co-chairman of Gimacon 2022, Dr. Deepak Kumar Mehta, Dr. Neeraj Chavda, Scientific Committee Chairman, and Dr. Kailas Ben Parikh, Chairman of Registration Committee. Then I request our Organizing Secretary, Dr. Pragnesh Shah, to felicitate Joint Organizing Secretary, Dr. Dhaval Mehta, another Joint Organizing Secretary, Dr. Mahesh Bhatt, please be fast. Then our Chief Patron, Dr. Jagdish Patel sir, to come on the dais. Dr. Pragnesh will felicitate him. Now I request Dr. Jasmine Jasani, who is an in charge of registration committee. Dr. Chetan Patel will felicitate him. I also request Dr. N.K. Chawla, who is in charge of food and venue committee. Dr. Chetan Patel will felicitate him. You all are enjoying very delicious food. It's the hard work of Dr. N.K. Chawla sir. Now I request Dr. Samir Shah sir to felicitate in charge of travel and accommodation committee, Dr. Rahul Parmar. In charge of entertainment and cultural committee, Dr. Kalpit Bakshi. In charge of memento and kit committee, Dr. Suresh Damor sir. Then I request Dr. Mehul Desai Sahib to felicitate in charge of audio visual committee, Dr. Asutosh Singh Rathore. Then friends, चलो फटाफट करो. Then I request Dr. Dainik Savani, in charge of audio visual committee, to be felicitated by Dr. Mehul Desai. I request Dr. Nitin Shah, in charge of stall committee, to be felicitated by Dr. Mehul Desai. Then I request in charge of paper poster committee, Dr. Rinki Shah and Dr. Vipul Gandhar, to come on the stage. They will be felicitated by Dr. Mehul Desai.
And I request Dr. Bhupendra Kapadia, the excellent MOC and in charge of souvenir committee, to come on the stage. Let's have a group photo on the stage.
हाँ सर